So good afternoon, everyone. I welcome all of you onto the second day of BIC 2020. Today's session is on unprotected left main interventions. I'd like to call upon our moderator, Dr. Samir Gupta, who's Director Cardio Cath Lab for Metro Group of Hospitals. So I welcome you and I hand over the sessions to you, sir.
Thank you so much, Shantanu. I would like to welcome everyone over here to the second day, Hall B of Best Interventional Cases. The session today, the next 2 hours, we'll take you through this whole gamut of unprotected left main, which is one of the most critical things when you think of PCI. We'll go through a lot of discussions. If you have any questions, please feel free to put them on the chat. We'll try and answer them. We'll see all these different cases, some nightmares and a lot of learning. With further ado, I'd like to welcome the chair people, Dr. Balbir Singh. He's going to be joining us shortly. He's the chairman of the Max Healthcare Group. Dr. Sudhir Rathore is joining us from the UK. He's the chief interventional cardiologist for one of the hospitals. Some of the panelists who are joining us today, Dr. Sahu. He's the chief consultant and head of department for the cardiology department at KIMS Bhubaneswar. Dr. Jaspal Arneja. He's the director of the Arneja Heart and Multi-Specialty Hospital in Nagpur. Dr. Vimal Mehta, he's an assistant professor at GB Pant in Delhi. Dr. Bhanu Duggal, she's a professor and head of department of the All India Institute of Medical Sciences in Rishikesh. Dr. P.C. Rath, he's the head of department and Department of Cardiology for Apollo Hospitals, Jubilee Hill in Hyderabad. I would like to welcome all of you over here, and I'm sure with all the smart people around, we'll have a round of scintillating discussions. We have some very exciting presentations. I'll quickly tell you who the speakers are today. Dr. Balbir Singh, he's the chairman of Max Healthcare. He's going to be talking to us about, he's going to be giving us a key lecture on the master view for PCI. Dr. Ravi Gupta, he's a consultant cardiologist at Wockhardt, Mumbai, and he's going to be talking about not all trifurcations are the same. We have, after that, Dr. Nabaljeet Talukdar. He's from Batra Heart Institute, and he's going to be talking to us about a nightmare blues, some fun case, I'm sure. After that, we have Dr. Anuj Sarda. He is from the Intima Hospital in Nagpur, and he's going to be talking to us about crush, crash, and crush. Then we have Dr. Ajit Pal. He is joining us from Jalandhar. His case is going to be on left main bifurcation PCI in elderly. We have Dr. Ajay Swami. He's going to be talking to us about Burke cut expand before stents. And Dr. Swami is joining us from the Command Hospital in Bangalore. We have Dr. Sumay Patra. That's going to be another interesting case, pseudoaneurysm of LAD and plaque fissure of the left main, guided by IVUS-guided PCI. He's joining us from Kolkata, from the Medica Hospital. We have Dr. Shailendra Trivedi. He's the primary PCI in a case of LAD diagonal bifurcation. He's joining us from Medanta, Indore. And then we have Dr. Nitin Modi, who's going to be talking to us about in left mains, all wells that ends well. So we have, you see, we have this nice mix of cases, a lot of learning. And I think let's start with the first case of Dr. Ravi Gupta. I welcome you, Dr. Gupta, from Wockhardt on your topic of all trifurcations are not the same.
Thank you, Dr. Samir. It is actually a very good platform where we all are interacting with each other, and good to see so many senior people, old colleagues here. So am I on screen? My presentation is on screen right now?
Yes, we can see you.
Yeah, so the topic which we are going to discuss today is, we are discussing primarily on left main, but left main become complicated whenever we are talking about the branches of left main. So, and people keep on talking about the bifurcation lesions. And today I thought that I must pick a few cases which are actually trifurcations. So it is rather more interesting, and I picked a few of my cases which are trifurcation, and each case is different. So I just want to share a couple of them. First case which I'm going to show is a male of 78-year-old male, which is having disabling angina with maximum anti-anginal therapy. So we need to intervene. And he underwent an angiogram 6 years back also. At that time, he was advised for CABG, for which he refused, considering his age. But now the symptom become more, so he agreed to go for any procedure except bypass. So this was the condition, and this is the angiogram. So you see that the left main is more or less healthy, but all the branches of left main are actually diseased. So you can see the LAD is diseased right from the beginning. There is a big ramus, a big circumflex, and the right coronary artery is 100% occluded. So it's a CTO. So clear-cut case for a bypass surgery. I try to convince him again, but clear-cut no for bypass. So first I fixed the right coronary artery, considering this is the dominant artery. So I didn't want to take any risk of left main without treating the right coronary artery. So it was not a difficult case. I had to use Fielder FC wire and then put 2 stents in right coronary artery, and the right coronary artery was clean. After treating right coronary artery, I staged the left system. This system, we cross all 3 branches of the left main by 3 different sine wires and balloon first with a 210 balloon, and after that 3/6 balloon. And luckily these all balloons give way very easily, so these were not hard lesions. So I was lucky in this aspect. Then as you can see that left main is very petulous, and I have to start right from the distal part of the left main. So first we took 2 stents, keeping all 3 wires inside. One wire, one stent 2.75 into 48 into LED, and another is in ramus 2.5 into 28. And checked in 2 classical views which we do in left main cases, areocaudal and apicaudal and aleocaudal. So these are the 2 views conventionally we check our stent position, and inflated both the stents together. It looks fine. Then I took a 3rd stent in circumflex and took 2.75 into 28. And here also we deployed the stent, keeping just the proximal marker inside the stent. Then we ended up with kissing done with 2 balloons. One is small balloon of 3 millimeter size in circumflex, and one is the ramus. And next set of kissing was done in LED and ramus together. So this was the sequential kissing was done, and this was my final result. So the patient is doing well. This procedure we did almost a year back, and patient is in routine follow-up. He is doing fine, no angina. Another case is a similar situation, but the lesions are different. The trick is also different from the last one. That's why I picked up different techniques in different cases. This is 65-year-old male. He had multiple fractures in the right lower limb. He underwent multiple surgeries, and he started walking very slowly with a stick. Then he noticed an angina. And this angina was troubling him to the extent that he was not able to walk even with slow pace. So his normal routine ECG and echo was normal, but considering his classical symptom, I advised for an angiogram. This was the angiogram finding. You can see that's a big ramus artery arising from the left main, and LED ostial is diseased, distal circumflex, mid circumflex, proximal circumflex, and distal left main is also diseased. And the right coronary artery is also having a tight lesion in the mid part. So first I fixed the right coronary artery. So I did not include those tests, those images here because of the limited time. And I started doing this case with an intra-aortic balloon pump. So this was the lesions, and this is how I planned. I again put 3 wires in all 3 branches, and now you can see that all 3 wires in the 3 branches of the left system. Then first I took a stent in the left main to LED, and then we ensure, I could put the wire inside also, but to be on the safer side, I took my wires out because I am afraid of jailing the wires. So I confirmed the position of the proximal part of stent in epicranial view, and then deployed it. Then I took 2 stents, one is 330 and one is 3.530 in the ramus and the left circumflex artery. And this was done with the kissing here. Then I did the next kissing in the LED and ramus, and Then we did the pot with a 4 millimeter balloon in the proximal part of proximal and mid part of the left main, and this was my final result. And this patient is also doing clinically. And the third patient, it is actually the most interesting and the most, I would say, challenging, and I was least interested to perform this case. He's 38-year-old male. He's a non-diabetic, but he had just a positive family history and effort angina. His angiogram was done somewhere outside. He was advised for a CABG, for which he straightforward refused. EF is 35%. And the reason behind it that he had some bad experience of CABG, which we have seen that several patients who had some patient loss in their family with either angioplasty, they will go for a CABG. If you have lose someone in CABG, they will prefer angioplasty. So this was the angiogram. You can see that's a tubular left main, long, and the distal part of the left main is diseased. There is a big ramus arising from here, and both LAD and circumflex are reasonable size. In this scenario, my plan was different, because if you see carefully, I assume that the left main is continuing as in ramus. And normally what we do that we put a stent from left main to LAD, and then rest of the branches we do either by kissing or reverse crush or whatever we do. But in this case, I planned that I will put a stent directly from left main to ramus, and then I will do kissing in either circumflex and LAD later on. So we did sizing of the lesions here with balloons, 3 wires in all 3 arteries. Here is my stent. This is 322 stent from left main to ramus. And at this point of time, my both wires of LAD and circumflex are out. And once I deployed my stent, I recrossed my lesions in LAD and circumflex, and then took 2.75 into 38 in LAD. And while deploying the LAD stent, I kept a balloon in the left main to ramus. It is something like a reverse crush. So then I deployed circumflex stent in a similar fashion. And after doing this, this is the circumflex stent being deployed, keeping one balloon in the left main proximal part. And after doing this, we are just assuming that I am away from the LAD ostium here. So I did a kissing, keeping one balloon in the distal part of ramus, distal part of the left main, continuing into ramus and circumflex. And this was the kissing with, again, next kissing with LAD and ramus. And this was the final result. So this patient is also doing well. His EF has not much improved. I would say it's around 45%, but he is now absolutely free of angina or any heart failure symptoms. So to end up my talk, I would just give few take-home messages. One is that the most important thing that we doctors keep on dealing this type of sick patients very regular basis, and we need to make them understand that these are actually surgical cases, because we should never be put behind the bars that you treated a surgical case. You should leave a clear-cut opinion that this is a surgical case, and if you are not agreeing for surgery, then we are opting for an angioplasty. Another thing, we need to understand that trifurcation is a different ball game, and every trifurcation is actually a different scenario, and each patient, each lesion is different. So we need to consider the angles between the left main to LAD, left main to ramus to circumflex, then relations between these two, it means the angles between the LAD to ramus to circumflex. These all decide the strategy for which you are going. Another message, because I am happy to be here on an international platform. So we have been talking about bifurcations, classification, but till now I am not aware of any classification of trifurcation lesions. So I want that as we are having now more and more robust healthcare systems, we have good hardware. So why don't we pick up some trifurcation classification also? Probably it will make the young people attempting more trifurcation cases if we define some classification and we define some strategy. This is my whole talk, and thank you very much for your patient listening. Thank you.
Thank you, Dr. Gupta. I think that was some very interesting 3 cases you showed us of different types of trifurcation. It's a trifurcation, you're right, is absolutely a different ball game. I would like to open the question to any of the panelists if they have any questions. I don't want to hog.
I'll just make a brief comment here. A very good case, Dr. Gupta. Clearly, every trifurcation is different, as you have shown, and the major thing, obviously, the classifications are important in terms of trifurcation should be considered as 2 bifurcation. But most important thing is the plaque burden at the ostium of the side branch. That is the most important thing. And it all depends on how much disease is in the ostium of the side branch compared to the main branch or the mother vessel to decide on your treatment strategy, whether you need to put a stent in or you can just do a crossover stenting and achieve a flow. So that is, I think, what is the classification helps.
Yes, sir. Fully agree with you, sir. Fully agree with you.
Okay, comments from other panelists?
One question which I had, Dr. Gupta, was that, you've done kissing stenting, which is obviously, but, have you thought about like 3 balloons and kissing all 3 together?
Yeah, it could be done. I mean, in that situation, probably I need to have an 8 French guiding catheter, or I could end up with 2 6 French or 2 7 French guiding. So this was probably 2 possibilities I can keep in mind if I am planning for 3 balloons altogether.
Yeah. This is Dr. P.C. speaking from Hyderabad, Apollo Hospital.
Yes,
Hyderabad.
Sir, good afternoon.
This is, you have done very complex trifurcation angioplasty and stenting. You have used all diffuse disease. You have used 3 stents. You do imaging. See the end result.
I usually do imaging, but unfortunately, neither of these cases has imaging. The reason behind, because in all 3 cases, actually, there were financial constraints. So, but I agree, imaging would have been definitely a choice and should be done. But neither of all these 3 cases had any imaging. I prefer to do.
Angiography result was excellent. I must congratulate you. I think I would like you also agree that imaging would have been the real answer.
Yes, sir. Yes, I fully agree with you.
Should have been done in this because you are using 3 stents and there are diffuse disease and size of the vessels around 2.5 like this. Most of them.
Yes, sir.
Especially, I wanted to see the first case whether the left main is been pinched, where you have used all the 3 stents in the vessels ostium of all the 3 vessels. That would have given us some insight into what is happening inside. Thank you.
Very true, sir. Very true. Fully agree with you. Fully agree with you.
And Ravi, do you use IABP regularly? Use of IABP in left main? And I want to ask the other panelists also.
Yeah, Bhanu, actually, what I do that when I have native right coronary arteries healthy, in that situation, at times I keep IABP just standby. But if I am dealing with the left main, when right coronary artery is either non-dominant or dominant but with disease, in that situation, I will keep intra-aortic balloon pump to start with. This is my strategy.
I think ejection fraction.
And Dr. Raghu wants to say, anyone wants to add?
I think ejection fraction also plays an important role in trying to decide whether you want to add hemodynamic support, like you showed in one of those cases. The EF was 35% the last case, but you were able to,
yes,
right, you were able to get away with it.
Yeah, I think that's correct. So it all depends mainly on the left ventricular function. If the left ventricular function is good, then it is not required. But in cases of, if suppose there is a lesion in the right coronary artery as well, it's a good idea to do that right coronary artery first, so that you got some reserve and then do the left main stem. And clearly you can keep it on standby. But if the ejection fraction is low, I think if putting upstream helps in reducing the complication perioperative, then the outcome could be removed just after the procedure.
Yes, sir.
And the imaging is very important because the problems are whether the stent is optimized in the left main stem. is the main issue basically, to make sure that because there's a differential in the size. In the branches, it is okay. Whether you do crossover stent or depending on the anatomy, mini culotte, DK crush, but it depends on the proximal part. So more and more people now try, if the left main is short, to cover all the way up to the ostium of the left main. If it is long, then you can cover up to the middle, but that is the area which you have to decide, and which stents will go up to 4 or 5 millimeter when you're choosing the stent size, because they are like 3 millimeter stents are okay, which can go up, but sometimes we put 275 into the circumflex, into the left main. It is difficult to take them up. So knowing your stent as well, how big will they go with the non-compliant stent, because that's where the outcomes depend on how the stent is optimized in the left main stem. That's where the imaging helps. I think it's a 1B indication now for left main, at least you try and use a stent mainly for this reason, to make sure the stent is well optimized in the left main stem.
Yes, sir. Yes, sir.
I think let's continue our presentations. We have a next presentation from Dr. Talukdar, a Nightmare Blues. He's joining us from Patra Hospital, where he's an interventional cardiologist and an electrophysiologist. Dr. Talukdar.
Yeah, I stopped sharing. Thank you, Dr. Samir, Bhanu, Dr. Rath, everybody.
Hello, am I audible?
Yes, sir, you're audible. We cannot see your slides. We cannot see your screen.
Yeah, I'm going to share my screen. Please enable from your end.
Okay. Can the support team help over here? Can somebody from the support team just help Dr. Talukdar?
Yes, Dr. Talukdar, how are you able to share your screen? If you could just scroll towards the bottom of the screen, you will be able to see the share screen option.
Muted.
Dr. Talukdar?
I am muted.
No, sir, you're not muted. We can hear you.
Okay, I'm just sharing my thing.
Sure.
While we were waiting, Dr. Rathore, there's been a lot of discussion in the scientific cardiology community and the cardiac surgery community about left main. This is the topic about left main right now. About Nobel, Excel, syntax, the primary endpoints, secondary endpoints. What are your thoughts? Like, has left main intervention reached prime time? Do we still have a way to go? Imaging, non-imaging, new stents?
I think clearly we need to improve the process when we do the left main stem in terms of quality. The trials, most of the trials have shown that you have to do some kind of risk stratification, or you do some kind of syntax score, Euro score, and the outcomes in low and intermediate score are equivocal with coronary artery bypass surgery. It all depends. So in terms of the long-term outcome, hard end outcomes, major adverse cardiac events are similar, but there is a slightly higher risk of repeat revascularization and repeat repeat interventions in the angioplasty group. So I think it depends on the case-by-case basis. And we discuss all our left main cases. If there are complex in our multidisciplinary team meeting, I'm sorry, there is some background. My fire alarm has gone off at house, and there's two things going at the same time. So we discussed. So in terms, somebody mentioned, one of your colleagues, that we should not be behind bars or things like that. So I think you should need to have a robust multidisciplinary team meeting or discussion, which might include just a cardiologist, non-invasive cardiologist, and a cardiac surgeon. Sit down together, have a look at it, do some Euro score, syntax score, document it, take patient preferences, and make the documentation reason for not doing surgery. And sometimes if the surgery will be better, patient is refusing, then we need to inform the patient. My thinking is that patient will go with how you explain the procedure to the patient, because nobody likes surgery. Take it on the face of our patients also say we don't want to have surgery. But once we explain to them that this will be a better thing for them, if you think that will improve their outcomes. So I think we should go by that. In terms of, I think we need to have good, the problems are you need to have good lesion preparation, use of imaging, good quality stents. So I think the things are still evolving. And the other thing is that this thing about 2 stents, 3 stents, I think we should try to follow the guidelines. Now, one of the Dr. Gupta mentioned about there's no classification for trifurcation, but the trifurcation should be considered as like 2 bifurcation. You should consider a main vessel and how the ostium of the branch looks like, and this is how you deal with it. And you try to keep it simple as well, as people say, because it's not always necessary to put 2 or 3 stents. You should decide the main vessel, then do the left main into main vessel, then assess the ostium of the other vessel. If it is very focal, branch is not very big, then just you can get away with some kind of a kissing balloon. And there's an emerging concept now of using drug-coated balloon to the ostium when you do kissing in, like if there's a left circumflex which is non-dominant, or even dominant for that purpose, if the lesion is not extending too much into the circumflex, stent left main to LAD, then open the struts gently and do the drug-coated balloon. Because the restenosis rate, whether you do a 2 stent or single stent, are more or less similar. The stent thrombosis risk is a little bit higher. So at the end of the day, you have to keep, if the flow is good in the side branch and the residual stenosis is less than 50%, some people use the FFR in this situation if there's a big bifurcation, if the FFR is good. So I think more incorporating of physiology and imaging will improve the outcomes. I know there is an immediate outcome, which is post-procedural. It should look good, but then we should look about durability of the procedure. What will happen to the patient 2 years, 3 years down the line? That's where the surgery scores over angioplasty. Angioplasty is less invasive immediately, good results, but the outcomes will depend on how well the procedure is done and optimized. And then I think there is still evolving. I know there is not much interest in the trials at the moment, but there are things going on. There's an October trial going on, which is a trial looking at role of OCT in bifurcation, large bifurcation, which looks at how you cross the side branch. Suppose you do left main to LAD, and then the wire crossing, and the hypothesis is that if you cross the distal strut, that will be better. But that only you can tell with some kind of imaging where you are crossing, how you're optimizing. So October trial is looking at the impact of imaging like OCT for big bifurcation, randomizing to with or without OCT. So I think it's more about the finesse now, improving the quality of the procedure and durability. The stent comes into play, plaque modification come into play. You do a good dilatation, even rotational atherectomy, OPN, NC, shock balloon. So utilize those things and imaging, and use imaging upstream. So I think it's those kinds of things impact the outcome.
Yeah, you bring up some great points. Side branch restenosis remains the Achilles heel of bifurcation, and hopefully with the more liberal use of imaging and being more cognizant whether we need to stent the side branch, I think that we will consider. I hate to, we'll talk, I'm sure, during the course of the discussion.
Sure, yeah, you should carry. If the next presentation is not playing, we should.
Yeah, we're just going to
speak the next one.
Yeah, so that's exactly what we're doing now. We're going to skip to the next presentation. There are some technical issues over there, but the next presentation is by Dr. Anuj Sarda, and it is on crash, or crush. And Dr. Sarda is joining us. He's the director of Intima Hospital in Nagpur. Dr. Sarda? Dr. Sarda, you're on mute. Can you unmute yourself, please? Dr. Sarda, you're on mute. Yep.
I'm audible?
Yes.
Okay. Good afternoon. Good afternoon, everybody. My today's concept is basically a crash, which land up into crash and followed by crash, and mini to mega crash. Let's start my case. My case is 77-year-old gentleman, known diabetic, presented to me with a history of recent onset chest pain with STD changes and no regional wall motion abnormality on echo and normal LV functions. Labs are within normal limits, including the biomarkers. And so diagnosis of CAD and unstable angina was entertained in this case, and we have planned for the angiogram. This is the angiogram, which shows significantly tight distal left main lesion, followed by proximal LAD tight 90% lesion, and there is a tortuous lesion, around 80-90% lesion in the circumflex, with associated with bit of calcium. The age is 77 years. And as far as the distal distal targets are concerned, mid and distal LADs are normal, and the circumflex is also well flowing without any significant distal lesions. And RCA shows some non-significant plaques. So the concern is how should we go ahead? The first option, in view of diabetes and view of old age, the CABG is the concern, the first concern. And the second, we have given the option of left main dedicated bifurcation stenting. And the third, definitely sometimes because of these constraints, the medical management, even though in presence of unstable angina, it's not rational to go ahead, but still we have given the third option of medical management. They have consented for the left main angioplasty. So we go ahead with the approach. The left main cannulated with extra backup this time, 3.57 French with femoral approach. The LAD and circumflex, they are wired respectively with Fielder FC and cyan blue. And prophylactically, we have put the temporary pacemaker in C2. The first, the LAD was dilated with 2x15 balloon. The result is okay. We have cracked open the lesion at LAD, and this is what the post-dilatation result at LAD. Now this is the time to deal with the circumflex. This is tortuous lesion and bit of calcium is there. First initially dilated with 2x15 balloon. In view of the calcium, presence of calcium, we have dilated with 2.5x12 NC balloon. This is the result after the dilatation with 2.5x12 NC balloon. And just for the sake of dilatation in the LAD as well as for the sizing, as we have planned for the mini crush. So particularly in this case, so we have dilated, we have taken 2.5 to 38 balloon for the purpose of dilatation as well as for the sizing also. So the first, we have put a stand of Zines prime 3x23 and circumflex, and in the LAD we have taken 3.5x38. Our plan is to go ahead with the modified mini crush. But this is the time we have phase scare. The patient become unstable, associated with bradycardia and hypotension. Fortunately, we have pacemaker in C2. So we have to just increase the doses of NORAD and the adrenaline this time. This is the time in the hurry. We have deployed the circumflex stent at the 16 atmosphere as per our plan. And followed by, we have deployed a stent of the LAD. 3.5x38, and we have crushed the stent with the LAD one. So this is the result after the circumflex. So what happened actually in our case? What happened wrong in our case? If we just go through the previous slide again, in this, we have crushed the stent. It's converted into a mega crush and hurry in comparison to the mini crush, and we have crushed the balloon in C2 with the stent. So stent in total with balloon is crushed but fortunately we are able to get rid of the balloon easily. So now we have with the options: should we leave as such, or should we go ahead with the various optimization therapy and optimize the result of what we have done. So we have planned to optimize our result. So initially I have removed the wire from the circumflex, which was jailed. The balloon I have already removed, and I did a pot at the ostia in the proximal part of the left main, and dilated with 4/8. This is the proximal optimization of the left main. This is the result. This is the stand boost result. This is now this is the time to rewire the circumflex after the pot of the left main. Sometimes it's difficult, but sometimes it's so easy, particularly when you face some sort of scare. I think the God vessel. So this time the wiring was pretty easy, and we have crossed the circumflex stent, and now this time we have dilated the struts with the help of 1.0 NC balloon, and now this is the time to do a final kissing balloon.
We've lost audio over there.
We have lost the thing.
I really want to see what happened. Doctor, we cannot hear you. We can see the slides, but we cannot hear you. Dr. Sarda.
Yeah.
Yeah, now we can hear
now
you.
It's audible, sir. So these are the final results with the TB throw flow. That's why I put my case as a crush followed by crush again. So this time it's not a technical crush, it's a crush of so-called relaxation or so-called of relief or so-called solace of the case, what we have saved the case. Even the strategies differed from mini crush to mega crush, but anyhow, the patient is saved and it's okay. He's doing well right now. So my take-home message is left main bifurcation strategy, as we have already discussed, a well-defined and the established technique in the field of intervention cardiology. And for most of the time, for the complex cases, you should always have a backup plan. Sometimes you have to take spontaneous decisions. These are really important sometimes. And you should have well versed with all the techniques and the armamentarium, and you have to update your armamentarium sometimes. And the most important two things in our case: keep your nerve calm at such type of pain, and definitely it's always a team affair. Thank you. Thanks a lot.
This is a good case, Minicus. I think you did it. And can you hear me?
Yes, Dr.
Yes,
Raj.
I think it's a good case also for Culet, because the circumflex is a large vessel, tortuous, and Culet is also a very good option for these patients. And this mini cross or Culet is ideal for this type of patients because angle is around 70, large vessels, and difficult anatomy of the circumflex. So first we have to stay branch in this case, either with Culet or Minicus, and then go ahead and do it. Again, I must emphasize that you are using 2 stents, and the young patient, I think you should have imaging to optimize the result.
A good case, Dr. Sarda.
Thank you, sir.
I think the intermediate, you did all the right things. It was you were trying to do the mini crush, but you do the crush. Now in these sometimes cases, I do a two-step process in crush. I've seen it could be done in two different ways. Because the lesions were so tight in the ostial circumflex and ostial LAD, when you put two stents, like you put a stent in and you do a circumflex stenting, then take the balloon out and then put the LAD stent. So there was a reduced flow at that time because the stent caliber is the two stents, undeployed stents were there, and that reduced the flow into the left main territory. So what I do is I take a circumflex stent. Definitely you have to put the stent in the more angled vessel first, circumflex stent, but keep a balloon into the left main into LAD. Across it rather than another stent, and then crush this stent first with a balloon, take that balloon out, and then bring the second stent which goes into the LAD. So if you do a two-step process, that might be less hemodynamic compromise if the lesions are very tight.
I do agree with you, sir. I think the better strategy in this case, either the first, I think it's better to go ahead with the DK crush rather than the modified mini crush.
Yeah, I think that is the better technique. Yes.
What we have retrospectively analyzed, and second, sir is rightly said, in such cases we can think over the culottes also, particularly when the lesion is angled and you are dealing with some difficult or tricky circumflex. These two techniques we retrospectively think we can think of.
Yeah, completely agree. Any more comments from the panelists?
Sir, one more question. Can I ask one more question to the panel?
Go ahead.
Sir, can we think the TAP in this case? Because I have presented this case to our meeting also, though they say you can go ahead with the TAP. So do you think the TAP would be a choice in this case?
Yeah, the thing is, if it is done well, any technique it could be good. But if you look at the data, there is now some data about randomized data comparing culotte and DK crush, in which DK crush has better outcomes. And there is some data in TAP and DK crush as well, or TAP and culotte. And the results for the TAP are slightly inferior, TAP and culotte both. I know technically it is a choice. It all depends on the technique, and you need to get out of the situation with good blood flow. But TAP could be done as well. You do the left main into LAD stent, and then put the stent into the circumflex with one or two stent struts hanging into the left main, and deploy it. It reduces the step. If obviously DK crush has got multiple steps, so you have to be used to all those steps. A similar culotte, and TAP has got a little bit less steps. You don't have to recross. You just put the stent in the circ, just pull it out and do a. But I think the results are a little bit inferior. You have to think about restenosis when the patient comes back. If he has a restenosis of the ostium or the circumflex with TAP, it will be slightly a tricky challenge to deal with it.
You know, I'd like to make just one quick comment before we go on, because I think we're running short on time also. One thing which I keep ready in my practice is that it depends upon the clinical situation. If it's an unstable patient and, you know, you have to do it, then just in and out, I think the fastest is TAP, at least in my experience for me. And the other thing, you know, we often talk about DK crush, but one of the other persons had pointed this out to me once, that the inclusion criteria for people who were eligible to be in the DK crush trial was very, very stringent. They were like expert operators doing X number of bifurcations. So we just have to think about that as we make it the standard in the community, because not everybody has such high volumes bifurcations in the community. You know, all of us over here are experts who do this routinely, but you know, there's just something to consider. Like I think Dr. Rathore mentioned, quick in and out is, or whatever you're comfortable with. I think we should go to the next presentation. Dr. Talukdar, is your presentation ready, Dr. Talukdar? We cannot hear you.
Yeah, while with Dr. Talukdar is presenting his case, any comments, Dr. Swami? I can see Dr. Swami as well.
Yeah, I don't know. Am I audible, sir?
Yes.
So I think the points made were excellent. This is about a comment on DK crush. That is now our default strategy for left main bifurcations. And I'm going to show one case like that. Ideally, even in the DK crush 5, they recruited operators who had done a minimum of 25 DK crushes. And I think it's important to go through a mentoring phase before one starts to do independent left main bifurcations. And, you know, then sometimes basic errors like crushing a balloon or crushing a stent while pulling out the side branch balloon which has already been inflated, the stent has been deployed, one can end up with a crushed mass of metal in the left main, and then it becomes very difficult to manage. So
okay, let's go on to those are all very good comments. Let's go on to the next presentation and we'll carry on with the discussion. Yes, Dr. Talukadar, go ahead. Yeah, we can see your presentation, Dr. Talukdar. Go ahead. Maybe you have to unmute yourself.
Am I audible?
Yes, go ahead. Go ahead.
I'm so sorry for all this fiasco. Well, straight away, I'll be trying to discuss two cases. Well, the first case is a 58 years old male. He's a diabetic hypertensive CKD and had been having some claudication. He presented basically with crescendo angina and some features suggesting left main this thing. His troponins were elevated and he was in accelerated hypertension, creatinine of 2.4, ECG, non-specific STT changes, predominantly multiple leads involvement. So I thought it might be a left main. He had an ejection fraction of 40% with preserved valve thickness. The right femorals were not palpable, and hence we took him for an angio. He had a bad descending thoracic aorta. The right femoral is right common iliac is gone. Left side is severe disease, so you don't have any access other than the radials. Choose radial, did an angio, distal left main showing tight lesions. Well, the computer decides to slowly respond. So there is a lesion in the main body of the circumflex also. The right side, the distal right artery was occluded 100%. It appeared to be a CTO. Because of the symptoms, ECG changes, echo features, we decided to go behind the left. So there is the distal left main where both the LAD and circumflex and pre-dilated. There are 3O balloon and 3O balloon at the LAD, 3O into 12, and similarly 3.5 into 12 in circumflex. We dilated at 9 atmosphere pressure. Then stented the circumflex lesion with a 3 into 24 stent euconylite. Then we thought that for the brevity of the case, we will do a mini crush. So put two stents, 3.5 into 24 at circumflex and 3.0 into 21 at the LAD. Deployed the LAD stent first with an idea of crushing the LAD stent later on with the circumflex stent. That's what we did. We took out the balloon from the LAD stent before. Well, then came the difficult question of recrossing it. It was almost impossible to recross. Tried multiple times. This is the step which took us 45 minutes. And after that, after a lot of struggles, I decided that I'll do a proximal optimization. So took out a 3.5 balloon, went into high pressure around 16, 18, tried with an attempt to open the struts. While this was successful, then we gradually pre-dilated the LAD struts with 1.5, followed by 2, followed by 2.5, and then went for a final case. Well, it was a well-deserved, long awaited case, which made us all happy. The patient became stabilized. In between, the patient threw one episode of VT, which was cardioverted, and the other episodes of VT was, we did the We did rapid pacing and then got rid of the VT. Finally, we got a good enough result. Immediate post-procedure, he had 4 sessions of hemodialysis, gradually improved. He had a contrast-induced nephropathy. Recently, 6 months back, he suffered stroke with right hemiparesis. He presented to the hospital late, so could not go for a thrombolysis. He's recuperating now. Current creatinine is 1.8. Angina is not there. We have put him on triple antiplatelets. Well, the next case is a little bit different. He is also 58 smoker and basically went into having TMT. At TMT stage 2, he crashed. There was an elevation in the AVR anterior leads, rushed to the cath lab. Right side, it was okay. Left side was very tight lesion in the circumflex. The patient has a VT at that moment. We gave Xylocard, esmolol, cardioversion, multiple cardioversion done. Then I thought that putting another guide and waiting for another thing will be a problem. Let me wire it fast through the diagnostic catheter only. So passed on a wire with the diagnostic catheter, took a dock extension, changed for a guide, and ballooned the lesion. As I put the balloon, you can see the AV synchrony came back and his heart started contracting in a better way. So we got rid of the arrhythmia. Then we had some time. So this was the lesion after dilatation. There is still some flow is there, but then, a very tight lesion. Now we are better. We at least have the access across the vessel. I was toying whether to wire the LAD or not. Then I decided that let me do as early as possible what is there. So already patient was on TPI. We had taken a left-sided 5F catheter before, so institution of TPI was easier. Now, after that, we put the stent. It is a 4.0 into 21 millimeter stent, 18 millimeter stent. After stenting, we saw that the ostia was not looking great. So actually ostia had to be, another stent was put in the ostia. Thus, we could open the ostia to an extent. There was 2 millimeter overhang of the stent into the aorta, which I thought was decent enough. Post-dilated with 4.5 millimeter peripheral balloon, and finally got a reasonable result. So this was the final angio. Finally, we got some good result. There was no VT here. Patient's BP became better. ECG changes settled. So left main disease can be disastrous, can have varied presentation. Ostial disease presents a challenge in terms of engagement and access. IBP is of great help in such cases. Innovation and speed is the key to success. Hardware management is prime. Thank you.
That's a great case. Thank you so much, Dr. Talukdar. Anybody have any comments?
Dr. Talukdar, this is a very interesting case. In your second case, I wasn't sure whether the images were projecting very well for me or not. To me, it was looking that this was just only a ostial left main stenosis. The bifurcation was clear, and there was
it was ostial left main. It was not a bifurcation. It was only a ostial left main. But crashing kind of a patient, throwing repetitive VT, and everything had to be done in hurry. I think while taking the stent, the ostia was missed, and resulting in slippage of the stent because the guide was there. I had initially thought of stabilizing the guide by putting another wire, but before that, before I could do that, the stent already, I think I missed the ostia, and that's why there was a need of second stent and post dilatation and there.
No, what I meant is there was no need for a stent to go across into the circumflex. You just stent the ostia and the body.
That is true. And, but sir, very short stent like 8 or 12 millimeter stent was not available then. It was at 2 a.m. at night.
That was my question. Do you have 8 millimeter? I would have used 8 millimeter stent in this case.
Yes, I would have preferred. 8 millimeter stent. Actually, the daytime, it was at night 2 a.m. Evening part like 2:30 or 3 p.m. and in the morning, short stent was already used. So whatever was available at 3.54, whatever length was available, I had to manage with that.
And we discussed earlier about the outcomes between surgery and PCI. This is one of the cases where the outcomes for left main, if it involves only body and the ostium and the shaft, not involving the bifurcation, the outcomes are, I think, better with PCI than coronary artery bypass surgery.
Yes, sir. At follow-up, this guy is walking around. He has restarted his, he is basically a carpenter. So he has restarted his carpentry, and he is doing great.
Dr. Rath, you have to unmute yourself. Dr. Rath, we can't hear you. Dr. Rath, you have to unmute. We can't hear you. Unmute yourself.
See, did you use any IGOS or something to see whether stent overhang or how was the scaffold?
No, IVAS was not used. Instead, after 6 months, we did a stress test. Stress echo is negative.
And sometimes in these cases, if you do it in an emergency, we always bring them back after some time. There is no harm in optimizing the stent a few weeks down the line.
There is no harm in optimizing the stent, but then this patient has got some financial issues, lot of things. He did not want to come again. All these parts were there.
Those have to be taken into account. So those are the factors which are never included in randomized trial, I'm afraid. So you have to take the individual patient situation.
So I think ultimately you have to see the results and whether he is having ischemic symptoms or not, whether the ECG is better or not, whether his LV dysfunction is persisting, lot of factors. Only imaging is not the only thing.
Okay, so
in the interest of time, if we just move ahead and then
we're going to move ahead. I would just like to take a moment over here and introduce our other chairperson who just joined us, Dr. Balbir Singh, who's the chairman of Max Healthcare. Dr. Balbir Singh, welcome to the panel and welcome to the session.
Yeah, Dr.
Hello, Dr. Balbir Singh. Good afternoon.
Hi, Sudhir. How are you?
I'm very well. How are you?
Dr. Singh is also going to give his give a talk on left main. It's the key lecture on master's view. Dr. Balbir, on to you.
Dr. Talukdar, if you can stop your viewing, only then I will be able to share.
Sir, stopped.
Okay. So I'm going to show you a case of, can you see my screen?
Yes, we can see very well.
So this is a left main bifurcation, some issues and some ideas how to approach this, because this is the most complicated area of left main. Otherwise,
Can everybody just mute who's not speaking, please?
So left main bifurcation is the area which we really need to work hard on. Can you hear me?
Yeah, we can hear you.
Yes, we can hear you.
So let's look at a case and try to understand. So this is a gentleman who had a previous stent to the circumflex from this point near the ostium to up to this position. He had a stent almost 6 months before he presented to us. Now he came with unstable angina, and this was the picture. We had an ostial LAD, we had an ostial circumflex, left main involvement, and big vessels. The LAD down was reasonably all right. So the right coronary was normal. So I did this guiding catheter is a 7 French through the femoral route. We wired both these branches, LAD and circumflex. We know this is the lesion. We know this is the lesion. And you can see this, the diameter of this left main is smaller than the diameter of the circumflex or LAD. So obviously telling you there is an involvement of the left main. So we have Medina 111 classification. We know we need 2 stents. We know that imaging is useful in this situation. We know there is some amount of in-stent restenosis. So this is an OCT catheter into the LAD. So we visualized from the LAD to the left main. So this is the LAD. So there's a branch coming out from the LAD, a diagonal branch. We see some calcium in the LAD from 9 o'clock to 12 o'clock, now involving in almost the full arc. There is calcium. Now we see tight stenosis. There is a ruptured plaque. And we come into the left main, realize 2 things, that left main is short and has disease. This is what these pictures were. So this is the arc of calcium involving, but at this point, you see the MLA is 12.37. This is the place where the lesion starts. This is the tightest portion. Here we also had a plaque rupture. This is the distal part of the left main just at the bifurcation. So you see this is the circumflex coming out here, and this is a small left main artery there. This is the previous stent, and we have in-stent restenosis here. You can see the stent struts here and dense neointimal proliferation. You see the dense neointimal proliferation. In the rendered stent, you won't see the stent because there is neointimal proliferation. So we know there is in-stent restenosis. We know this is quite aggressive and happened in a short period of time. This is the ostium of circumflex showing the tight lesion and marked neointimal hyperplasia. We realized the diameter of this vessel circumflex was 4, LAD was 4.2, MLA in the normal segment was nearly 10. This is the pullback from circumflex to the left main. And where we come to the left main, right. So now we have to take 2-stent strategy without any doubt in this patient. What are the aims of 2 stents at a bifurcation? Preserve the lesion coverage and avoid complexities, multiple layers, avoid, have a good kissing balloon, and trying to get what is the best technique varies from operator to operator. Presently, people talk a lot about decay crush technique, but we know decay crush has a lot of limitations. I've seen the best of operators not able to do the final kiss, not able to cross with the balloon, the crushed portion of stent. So I have resorted to doing nano crush for last 1 year, decay nano crush. So it's a very nice, elegant technique. So I'm going to show you the steps. So this is a beautiful article which looks into the hemodynamics and bioengineering, fluid dynamics of decay nano crush for bifurcation lesion. So this patient, after pre-dilating the lesion with a 3.5 millimeter on both sides, we got the first stent, which was a Zions 4x23 into the circumflex, placed it right at the ostium. So this is the placement of the stent. Just at the ostium, trying to cover this portion. I will explain you exactly by a diagram where exactly it is. So we don't get it much back, just inside the ostium. We inflate the stent, get back the previous balloon, do a kissing balloon with this balloon and the stent balloons. We had done it and then prepared the lesion. Get the second stent. This is a iliocranial view to place the stent right at the left main. Get this stent, deploy that stent, then do the final kiss. This is the pot, final kiss, and then OCT. So I will show you the OCT pictures. So this is the final result on this vessel. You can see the iliocaudal, areocranial, and iliocranial. These are the OCT pictures. This is the LAD to left main pullback. This is the stent. This lumen area was near the ostium around 12. This is from circumflex. This is where we had treated the instant. So this was near the ostium 12. This is from LAD to left main. The ostium area was around 11. And the left main area was around 16. So this is in the left main, this is on the ostium. So this is what DK nano crush technique is. You have two wires, you pre-dilate the two regions, place the stent in the side branch, place it so well that it covers the ostium with little bit overhang into the main vessel, like you see here. You inflate the stent, pull back the stent balloon, do a kissing. So this is the first kissing. You don't need to introduce the wires again to do the first kissing. Get the second stent, inflate the second stent, do the pot, recross, do the final kiss, and do a repot to complete the procedure. So these were the diagrams to show that any of the angles, you can get a very good result on a hemodynamic model. If we compare DK crush and DK nano crush, there are about 13 steps in DK crush. At least 3 new balloons, at least, there could be 5. Main branch rewire, not required in both. Side branch rewire, yes, but here you need to do it twice. You need to do twice, you need to get balloons into this. You can use a 6 French guiding catheter with DK nano crush. The careful part is the side branch stent positioning, because you just cannot afford to miss the ostium. So a little bit into the main vessel like you do for TAP, but covering the side branch clearly. That is the only drawback. Otherwise, this is a very elegant technique. And this patient did very well. He's 3 months follow-up and no angina at all.
And thank you, Dr. Singh. That was an excellent presentation on, especially on the optimal use of imaging in these complex cases. Anybody want to have any comments, any questions?
Yeah, Dr. Singh, great presentation. And I think the emphasis is more now on like mini crush and nano crush, because you try to avoid 3 layers of stent in the just proximal to the bifurcation. So in those in that way, the nano crush, if the stent is well placed, it reduces the steps as well, and it reduces the metal work at the carina as well. That's where the problem lies in the outcomes in terms of stent thrombosis, restenosis. So it's a very elegant technique. It just needs a little bit of learning, positioning of stents, and understanding. The other thing is understanding the stent in terms of distance of the stent edge from the radio-opaque marker. Different manufacturer stents have got different overhang. So you have to be very careful where you put your radio-opaque marker in the left main stem where you're positioning the circumflex stent. Some have got very little distance, some have got just on the edge. So I think stent boost and things like that are quite helpful in this regard. Very well done, Dr. Singh.
Yeah, absolutely agree with what you said. That one has to know the distance, because I use Zions, both of them, and we know the stent lies at the marker. The proximal marker is the stent. So you have to know the distance, because otherwise you can miss the ostium. I showed this presentation because people get carried away by DK crush, which is getting very popular. But I know there are a lot of issues with DK crush, the number of steps that are taken, and number of young operators get into complications with DK crush. So minimizing the metal at the ostium is very, very important.
And that is exactly what we were talking about earlier, that the DK crush is not as simple as everybody thinks it is. Even in the trial, they'd mentioned that your entry criteria were that you should have 25 cases. So, you have to be proctored before you start doing it. But yeah, that's great. Thank you so much. Anybody else have any questions?
See, what about the restenosis, sir? I mean, this patient had, as you showed, almost 360-degree arc, diffuse restenosis. So, I mean, from my perspective, anybody who has similar kind of presentation, so restenting, especially within 6 months, So he is likely to have restenosis with the next stent also. I mean, the chances are much more compared to a de novo lesion or first stenting. So in such a case, surgery should be the number one option. I have absolutely no doubt in my mind. I understand you must have offered him surgery. So what precautions, based on your experience, we can, in such a case, I mean, for those who are listening, I mean, somebody, let's say, had sirolimus eluting stent deployed earlier on, and he has come back so early, within 6 months. So obviously he has a huge kind of inflammatory response or whatever response is there. And so what things can be taken in, considering that, patient has refused surgery, and
So
we are talking of a high risk area, left main area, so
right.
which is in any case prone for all these complications.
Right. So, Dr. Vimal, very nice question. This was considered, and discussion with the entire family was done before we took up this case, which is very, very important to understand. He was definitely offered surgery. In fact, he came to me because he didn't want surgery and thought that I could handle this situation. Now, when I looked at the CD, the first thing that struck me that the vessel is about 4 millimeter, and the stent used was a 3 millimeter stent, which was post-dilated with the 3.5 millimeter balloon. So that was the first thing that struck me. The second thing that struck me was that it was a focal in-stent restenosis. And the third thing that struck me was the operator, in trying to avoid the left main, missed the ostium with the stent. So these were the three lacunas from the previous procedure that I got to see. And fourth, I made mandatory that I used imaging. So I used a 4 millimeter stent because the vessel was 4 millimeter, and post-dilated high pressure with a 4 millimeter stent, covering the ostium very well because I used a nano crush technique. So all these points are very well valid, that is the instant restenosis in the area, which is very dangerous. And one has to take all the due precautions to do this case if he wants to do it non-surgically.
So you have very nicely pointed out the point that optimal size of the stent, not leaving the any bare area, so and doing it as per the textbook. So that's the most. If one is not able to do it, one should not be attempting. I mean, in your good hands, perhaps this was a excellently handled case. But these cases these are not like de novo cases. That's what I wanted to emphasize. They are not like first time. If they were no stent, then things would have been maybe a little bit different. But this required real good handling, which you did, sir. Extraordinary, I would say.
Dr. Bhanudugga, how would you approach this in Rishikesh?
Yeah. So the first option given is surgery, and second would be, of course, bifurcation stenting, and the use of imaging. Yes, we don't have an OCT; we have intravascular ultrasound. And sir, Dr. Balbir, I would just like to ask, like, compare doing the stent size using OCT versus IVUS. Like in IVUS, we use media to media, and here, how do we size the stent with OCT?
Right. Very good question. So if I had an IVUS, I would have used an IVUS. So there is not much difference in this case, whether it is IVUS or an OCT. OCT I used because I was going to look into the stent restenosis. So I thought that would be a better idea. So IVUS, you measure media to media. In OCT, you measure external elastic lamina to external elastic lamina. The recent studies, if you heard Gary Mintz, the recent studies with the newer version of intravascular ultrasound, which has better resolution, shows these two measurements are almost equal. Earlier, it was shown that media to media was little larger than what EL to EL was on OCT, but the recent version of IVUS, which has high resolution, shows them almost to be equivalent.
Okay. Thank you.
No, I would just like to take this question on. We were talking about restenosis earlier. What's the panel like? Think that if somebody had a restenosis with a sirolimus, would you want to use a paclitaxel stent, or or would you change the drug also?
Yes, yeah, good question. I think there is no definite data about it, but I think it makes sense to change the drug at least. And in this Dr. Singh's case, it was like an in-segment stenosis, as he said. The ostium was missed, and it happens so commonly. If there's a true ostial lesion of either circosteum or LAD ostium, it's very, very difficult to just land the stent in that vessel. You have to come to the proximal part of or the parent vessel, if it is a daughter ostial stenosis. So that's one of the things in segment. And OCT might have little advantage in terms that you will also learn what is the cause of restenosis, because there could be, you can overcome that whether like in this case the stent was undersized and it was not, the vessel size was bigger. So there are certain limitations with IVUS, but I think both can be equally used, and we should try and change the drug on the stent next time. And the data is good for focal restenosis. The outcomes are pretty good with the drug-eluting stent.
Are there any trials on this? I mean, change of drug.
There are no trials at the
Because
moment.
initially there was, this thing was that if anybody has restenosis, you put in a cipher. There was initial, around 15 years back, there was one study. I won't be knowing the details, but cipher was considered to be final, answer to all these things. But after, sirolimus has gone into, now everolimus is this era of everolimus. So I don't know what is to be done. But
so I think there are several options at the moment. You've got everolimus, daughterolimus, so you can change the drug.
Yes.
And I think that makes sense. And the more important part than drug is to optimize that stent well, and considering what might be the reason for the restenosis. Because if you classify these restenosis, focal, diffuse, focal restenosis could be due to stent fracture, could be under deployment of the stent size not in line with the proximal vessel. So if you overcome those things, then outcomes are good. And as you mentioned, the risk of restenosis is higher for higher than the initial index procedure, but that's the best you can do. And obviously in this case it doesn't apply, but in focal, sometimes drug-coated balloon could be considered as well if it is a straight lesion, not a bifurcation. Drug-coated balloons are also not superior, but it can achieve a good result sometimes.
Though this is slightly off the mark, but I would say because in Dr. Balbir sir's case, we saw the disease, the whole artery is, has atheromatous plaques. The whole artery appeared to be both LCX as well as LAD. So very, very aggressive lipid loading therapy perhaps will ultimately help. I don't think it will help in the restenosis part, but overall in the long-term outcomes. So this has to be pursued very, very aggressively. In fact, we recently published our Indian guidelines from Lipid Association of India, where we in such cases we less than 50 and possibly less than 30 may be promoted. So maybe it's a free article from in Journal of Clinical Lipidology, so one can see it.
Yeah, it'll be interesting to see if the statin also reduces new atherosclerosis.
Yes, that's true. That's true. In fact, that is the in long term. Though this was only 6 months, so we believe it is neointimal hyperplasia, as sir rightly mentioned. But if it were 2 years down the line, then surely neoatheroma besides neointimal proliferation plays a very important role. So statins have a role in the long term basis, and we have to go for a goal oriented, very low LDL. Goals have to be achieved, and we have to ensure that. Because what I see is, I'm from GB Pant. You mentioned me as assistant professor. I'm not assistant professor. I'm professor of cardiology in the introduction. Nevertheless, that is a material. So the thing is that what we see, we do huge number of procedures, as many of you may be aware. So what I see is when patients are on CAT table, their BPs are in 180s, 190s, their cholesterol levels are totally haywire. There is absolutely, what we are focusing on is intervention and not on the secondary prevention situation. Patient will come for repeat stenting after in an interval procedure after 1 month, then his BP will be on the very high side. So we need to focus on that also. That was just a not directly related, but indirectly related to our discussions.
Yes, Dr. Mehta, I would like to congratulate you for a large volume and a good work you guys are doing in GB Pant, not in terms of cardiology, but with current pandemic as well. You guys are doing a great job. So
thank you so much,
sir. We should say this, that all these procedures, so complex strategies, technique we do, but there is another aspect of this is risk factor modification, which you touched on, like cardiac rehab, lifestyle modification, counseling, risk factor reduction. which plays an equal role. If you see the cardiac
Correct. That's
rehab
true.
in these patients reduces cardiac events by 30%, which the stent will never do. Stent is only for preventing further symptoms and things. It doesn't have a prognostic benefit in majority of the non-STEMI or ACS cases, but cardiac rehab, which is completely missing, unfortunately, in India and other places, is that has shown to reduce the recurrent event by 30%, which includes not only exercise component, but correcting your lipids, smoking, lifestyle modification, psychological counseling. So I think, and those things are little bit less, obviously less interventional type of thing, but I think we should pay a lot of emphasis. And low and middle income countries, I think they've got a lot to gain from those approaches as well.
Am I audible?
Yes, go ahead.
Yes, sir. Please.
In decay nanocrust, what is the long-term result? Restenosis, is it less than decay crush?
Okay, so I'll take this question. It is very difficult to say whether it will be less or more, but if you look at the
metal
imaging,
less, yeah.
so if you look at the imaging,
Yes.
this technique is very elegant because you have less metal layers, you have more ease of doing the final kiss.
Yeah.
If you miss on the final kiss, you are likely to have more problems. So decay crush technique, everybody gets carried away by the decay crush 5 trial showing it better than Coulard.
More steps, more difficult than this.
Yes. So, but can we generalize this technique? Can everybody do it? It's not possible. It's not going to be possible. The crush technique went into disrepute because of this reason, that the final kiss was not being able to do in 20% of the patients, which is very, very high. And same has happened with decay crush, that you're doing too many steps. And you need to learn. Decay crush, you have to do more frequently, learn it. There's a large learning curve. So decay nano crush is very similar, except that the kissing, again, recrossing is missing. So that instead of 13 steps, you have 8 steps, and you have less metal at the ostium.
Very nice. Thank you.
I think in the interest of time, we should continue with our next talk. We are running fairly behind. So our next talk is going to be by Dr. Ajit Pal, who's going to talk to us about left main bifurcation PCI in the elderly. And he's joining us from Capital Hospital in Jalandhar.
Good afternoon, everyone. Am I audible?
Yeah, please go ahead.
Yeah, I'm presenting a case of a left main bifurcation PCI in an elderly patient. My patient was an 84-year-old male who presented with angina at rest, and ECG showed ST segment depression in the lateral leads. Echo showed normal LV function with no regional wall motion abnormalities, and we took the patient for coronary angiogram. The coronary angiogram showed significant stenosis in the distal left main and a long stenotic lesion in the major OM vessel. And there is a long tubular stenosis in the LAD, and the RCA can be seen retrogradely filling from the LAD. The RCA was a CTO, and so we discussed the management options with the patient and relatives. Since the patient was 84 years old, the patient and the attendants, they straight away refused CABG. And so the next option we gave was for left main bifurcation stenting, to which they agreed. Patient was taken up for left main bifurcation stenting. I inserted an intra-aortic balloon pump to provide support during the procedure. And I pre-dilated the LAD lesions and took a long stent in the LAD. This was a 3/30 by 40 drug-eluting stent. And then I took 2 long stents again in the left main bifurcation. 2.75 by 40 mm stent in the left main to the OM, and a 3.5 by 32 mm drug-eluting stent from the left main to the LAD. This I did the mini crush technique. I deployed the left main to OM stent first, and then removed the balloon and the wire, and then I stented the left main to LAD, overlapping with the mid LAD stent. And then post-dilatation was done, adequate post-dilatation done of both the stents, and final kissing balloon inflation was done. This is the final result. The stents are very well expanded. Even the LAD stent is very well expanded, and I achieved a successful revascularization of the LAD and LCX vessels. The patient has been on follow-up with me for the last almost 2 years. I did a follow-up coronary angiogram from the radial route at 20 months. You can see the stents are very well patent. There is absolutely no in-stent restenosis, and the patient continues to be symptom-free on antiplatelets and antihypertensives and statins. So the take-home message is PCI is a viable option in elderly patients who are not suitable for CABG or who have refused CABG. Left main bifurcation PCI can avoid the need for high-risk CABG in such a population. Use of IABP during procedure improves outcome and is very supportive, especially when the RCA was CTO and we were attempting to do the left main bifurcation PCI. And adequate pre and post dilatation is imperative for long-term good results. Thank you.
That's a great case. Thank you so much, Dr. Ajit. Anybody in the panel have any comments, questions?
Great case, Dr. Singh. Could I just ask you, do you do report in all your cases, or clearly you did a good job? You did a crush stenting, recross, and did a kissing balloon. Do you do report after doing the kissing balloon routinely, or has other panelists got any view on that? Because that is one of the recommendations from European Bifurcation Club.
Yeah, I usually do POT in such cases, but in this case, I had used very long stents and I did not have adequate length in the left main. So I tried to pull back my kissing balloons into the left main so that I can achieve adequate dilatation of the stents in the left main. But since the stent length in the left main was a little less, so I didn't take a POT balloon into it.
You can obviously you sometimes need 8 mm balloon. If not, then you can just overhang in the aorta. If it's a longer balloon, you can use it in the left main stem and then go up to the bifurcation, put the dot against the bifurcation, and part of the balloon can overhang in the aorta. That way it could be overcome sometimes.
The left main ostium was not covered in this case.
Okay. So. Right. Yeah, so that's what we discussed earlier as well. In this case, the left main is not that short. So I think there is more and more people are adopting the strategy of covering all the way up to the ostium unless the left main is very long, because that's again problem. If you stent it halfway, then it is very difficult to do a pot in the left main stem, and the stents are differential. The LAD and circumflex diameters are 2/3, if you add those together, of the left main stem. So you have to do a pot in the left main stem to make sure that your stent is well optimized to the left main stem. And that is one reason that I think technically it is better to extend the stent all the way up to the ostium. I don't know what other panel member.
My take on it is inflating two balloons simultaneously. I mean, taking the kissing balloons a little, proximal will make the stent more elliptical, and may not be doing that much of a good, if not doing too much of a harm. So final pot is must, and if one is one should anticipate this kind of issue and take a stent a little bit, longer, 2-3 millimeter longer, so that at least 8 millimeter balloon can be used for doing pot. Because without pot and doing bifurcation, I think, both go hand in hand. You cannot do away without pot. Mother, you have to do pot ultimately to get, especially in left main. That's my take.
I have a suggestion for patients in whom, sometimes you don't have the length that you need, or you don't have an 8 millimeter or a 6 millimeter balloon for a pot. So you can keep the guide a little bit inside and make sure that half the balloon is inside your guide, and just keep the part outside that needs to do the pot. That's one way of getting past it, but the points made by the panelists are perfect. Ideally, if one is bringing the stent into the left main, it's a good idea to cover right up to the ostomy point.
So I have a question to Dr. Sudhir.
Yes, Dr. Singh.
Yeah, so this CTO of RCA looks very tempting. Would you have done it before the left main or after the left main?
I had tried it, sir, but I could not. Unfortunately, I could not cross the wire.
So that's.
Yeah, I think in the broader sense, if you've got a severe left main lesion and there is a lesion in the RCA as well, you try and attempt the non-left main lesion first, because that will provide you some security and for compromise. Because in this case, whole RCA is being supplied by the LAD. If during the procedure, left main LAD, if the left main goes down, then it is a serious problem for the patient. So all efforts should be made to try and recanalize if it is possible. But sometimes, if suppose in this case, there are good collaterals like epicardial collaterals as well, it's like a vessel continuing into the distal RCA. I think you have to be careful. You use the intra-aortic balloon pump, and the role for Impella also comes into play. If the LV function is severely reduced, definitely this patient needs to be done under some kind of LV support for the left main stem, because a hemodynamic compromise might happen. But clearly, this is an elderly patient. The RCA CTO will just be of prognostic benefit. So I think I would just leave it. If he has got any further symptoms, then it could be attempted again by an operator, which might be able to deal with it. We have to look for the safety and the benefit as well. I think the risk is higher in this elderly patient as compared to the benefit he's going to get. So I think the technique is one thing, doing is one thing, but I think we have to think about our patients and that long-term outcome for the patients. It should be patient-centered approach, in my view.
Yeah, I tried RCA both the times, sir, in the initial procedure and in the follow-up procedure, but unfortunately I could not cross. So I've left it like that.
I think in the interest of time, we should move forward and carry on with the discussion.
Our next talk is going to be by Dr. Ajay Swami on Burr Cut Expand, stunts before stents. And Dr. Swami is the senior interventional cardiologist in the Bangalore Command Hospital.
So if my slides are visible?
Yes.
Yes, sir.
Are they moving? Am I on? Yeah. So this is a story of a 79-year-old lady with severe COPD and bilateral osteoarthritis, limited effort tolerance, effort angina for a year and a half, crescendo angina for 3 months. She couldn't walk to the bathroom without symptoms. She had undergone an angiogram a year back and had been advised the CABG, was refused. And even on maximal medical management, obviously her symptoms had progressed. And she said that she was very clear she didn't want any kind of surgery. And I'm almost scared to present this case after so much of adverse comments on DK Crush. But let's see what we've got. If the angiogram is running, you can see this is an apicaudal and an aleocaudal view of the...
Doctor, your slides are not moving.
That is what I was asking.
Yeah, I apologize for that.
Technical support, can you help me? I'm going to stop and restart sharing once more. Is there somebody online, technical support?
Yeah. Why don't you click on your first slide? Yes, we're moving now.
No, this is not a PowerPoint. Is it visible now? First slide?
No, you just had the second slide. So if you just click again, maybe click on the slide.
Is the angiogram showing now?
No.
No, if you on the slide, if you click on the slides.
So you'll have to click on slideshow.
Okay, wait, let me try again. I'm so sorry.
It's the play button and it's the home, the last.
It's left down, only this thing, slideshow. Oh, the big TV box
Okay.
No.
You can cancel this.
On the, yes, here.
Is the second slide visible now?
No.
We just briefly had your second slide earlier. You did something.
If you go down by the slides manually, you may be able to do it.
Okay, so let's see if it runs like this. Is this visible?
Yes.
We'll run it like this, no problem. So this is what the angiogram is. Is it visible?
Yes.
Yeah, now it's visible.
Fantastic. It's not slideshow, but I think in the interest of time, we'll go this way. And this is what it looks like. In summary, this is a distal left main plus a bifurcation. This is a Medina 111 with a 90-degree angle between the LAD and the circumflex, and it is heavily calcified. I don't know if that point was sufficiently illustrated. So our strategy was to do a plaque modification and then a left main bifurcation with the two-stent strategy. We considered all the three: decay crush, T and protrusion, and culotte. And as I said, I'm almost scared to present this, but we chose decay crush as our strategy. We considered hemodynamic support. Ideally, yes, every patient with this kind of an anatomy, when one ends up occluding the distal left main, we must do it. But the dominant RCA was patent. The patient had normal LV function and a non-dominant circumflex. So we just felt happy with a 5F access with an IBP on standby. Elderly patients, tortuous vessels, putting in large bore cannulas, they have their own problems. So this is what we started with. We did a 1.5 millimeter rotablation burr. And we use, whenever we are doing a left main bifurcation, by default, we use a JL7 French or an 8 French. We use the 7 French because we like to keep control of where the guide sits when one wants to do two stents in the left main. And then, sometimes an EBU has a tendency to go and deform the stent, which we pick up on imaging later. And then it's too late to do anything about it. So this is a 1.5 millimeter burr at 175 RPM. And we never stop at that. So after the rotablation burr, we then do angioscalp and a cutting balloon. They have two different roles actually. So we used, for both the LAD and the circumflex, we used the angioscalp at high pressure and a cutting balloon almost 0.8:1 at low pressure for both. And then after that, the ideal situation after this would be to do an imaging at this stage. But our patient wasn't all that stable, pressures were borderline. So we thought we'll finish and then optimize at the end. We opted for doing a compliant balloon at high pressure, at moderate pressure, to see if there was any waste. There wasn't much of a waste, so we were confident that we would get good expansion in any case. Now, this is how we delivered the circumflex stent. You can see that there's a lot of calcium and there's a lot of difficulty. So we are very careful never to lose the wire in the main vessel, which was our LAD. And we inflated the balloon there and managed to deliver the circumflex stent, that is by the anchoring balloon technique. And this is the positioning and the deployment of the circumflex stent. Thereafter is one extra step that we do, which helps us to cross. Even after deployment of the first step, before crushing the circumflex stent, we pull the LED balloon back and do a kiss here at this stage, prior to pulling out the balloon of the circumflex. So this ensures that the part opposite the carina has very, very good apposition with that stent. And this is what we have started doing, and this helps us. And thereafter, we pull out the circumflex balloon and wire, and then crush this with a 1:1. This is a 3.5 NC. And then recross, open the stent strut, and this is the conventional first kiss, which is actually our second kiss for the decay crush. And then after that, we pull out the circumflex wire, leave it as a sepal wire so that we get the correct ostial positioning of our LM LED stent, deploy this at moderate pressure, do the first pot. So this is the first pot. If one does these steps properly, we never have a problem in crossing into the circumflex, and we are yet to experience much difficulty there. The issue is if our first kiss is done well and the pot is done well, the wire, you can see, just slides through. We don't have to do anything. There's no problem at all. The issue is if one is able to do the first kiss well, there is no problem in wiring the circumflex ever. This is our second kiss, serially, simultaneously, and at high pressure, and the final pot. Now, if you have a short balloon, it's important to do the pot in two phases. This is what we do. So we first do the distal part, that is the shaft, and then we do the ostium at high pressure I'm sure it's appreciable that they are both at actually different parts of the left main. And then we did our OCT at the end just to be sure that everything is fine. And these are our measurements of the OCT: 13.6, 13.8, 14.5, and 15.45 in the left main. And this was our final result after everything was out. And this is the before and after. This is what was before, and this is what we finished up at the end. I'm so sorry the PowerPoint, this one did not run on slideshow. This is a problem with our computers and our Zooms, but I think I finished in time and I should be glad for any questions. As I said, in front of such luminaries, I'm really scared to present DK crush. It's been abused so much, but it's a technique which is, you know, supported by evidence, and in our hands, since we've done so many, we are very, very comfortable doing DK crush in all kinds of, you know, high risk patients and all kinds of difficult anatomies. And I feel it offers excellent, you know, short-term, intermediate-term, and long-term results. Remember, when we're doing left main bifurcations, we are competing with the surgeons, and our long-term results have to be as good as them if we are to stand up in any forum and say that this is an option of treatment for our patients. So I think imaging is the second part. That imaging is extremely important. In an ideal situation, we usually image after we ablate, and that tells us whether the ablation is adequate or it's more. The other option in little unstable patients is to take a compliant balloon 0.8 and just inflate it and see if one has a waste. One need not go high pressure. Just at, you know, 10 atmospheres or so, you can see if there is no waste, you can go ahead and deploy. And eccentric calcium is a problem, but in this patient, we were lucky. We had concentric calcium and we had good results. Thank you very much, and I should be glad to answer any questions.
I have a small comment to make, because in a case where you have such a short left main, and we saw one case where, you know, small balloon was not available to do the pot. So one thing one must avoid is, once you have done the final casing and now you are heading towards the final pot, do not injure the carina. I mean, do not go into the carina or too much into the carina. Otherwise, you will mess up with it, and you know, the long-term result will not be good. If at all, as was mentioned earlier on also, that you can overhang the balloon a little bit, but the point is that you do not injure the carina with your pot technique once you have done the final kissing. Any, you know, I would like your comment on this statement.
So the joy of the imaging is that, you know, after you finish with the pot, you do the imaging, and if you have at all injured or deformed your distal left main, you can always correct it. I mean, obviously the basic common sense of keeping your pot balloon where it needs to be kept and not put it into the LAD or into the circumflex before inflating, that must be there. But the advantage of the imaging is that you will ensure that you haven't destroyed your carina or not damaged your carina. So with experience, we have learned where we need to keep. Not only are the stent balloon markers important, the pot balloon markers are important as well. Each manufacturer has a different amount of shoulder with the pot balloon. And with time, we have learned that the AccuForce is different from the Euphora, is different from the other pot balloons. And we have clear ideas of where to put the distal marker. But the imaging part is what ensures, you know, it's the insurance that you take. It's like a life insurance policy. Ideally, in a left main bifurcation, one must do some kind of imaging at the end, and ideally even before starting. As I said, our patient wasn't all that stable that we could do good amount of imaging prior, but we're quite happy with what we got. But the point is absolutely well taken. Basic common sense about where to keep the pot balloon is mandatory.
I think in the interest of time, I'm sorry to be a party pooper, but we have 3 more presentations and we are running really, really behind.
That's why I wanted to finish. Thank you.
Constantly reminded, but that's a great case, Dr. Swami. Thank you so much. Our next presentation is going to be Dr. Soumya Patra.
1 minute. I just need to unshare the screen.
Dr. Patra is going to be talking about pseudoaneurysm of LAD and plaque fissure of left main coronary artery treated by IVUS guided PCI. And Dr. Patra is a consultant interventional cardiologist at the Medica Hospital in Kolkata.
Can you hear me? Can you hear me?
Yes,
Yes,
slight
please,
echo, but go ahead.
Hello. Can you hear me?
Yes, Dr. Patra, go ahead. There is some echo, so just turn off your mobile or something. Better now.
Hello.
Yes, go ahead.
I'm going to present a very simple case of pseudoaneurysm of LHD, and there was a plaque fissure of LMCA, and our dignitaries will guide this case. And Gary Means was actually he was the IVAS interpreter of this case. Next slide, please.
Can the
Dr. Patra, can you turn off your iPhone?
Yeah, this can happen if one is connecting to two devices. If one is connecting to two devices, then this kind of situation can arise. So if you are connecting to two devices, kindly switch off.
A 60-year-old male who presented with complaint of chest pain in another hospital, and ECGs there showed that non-Q myocardial infarction, and his echocardiography revealed EF of 45% and RWMA was present, and angiogram was, next slide please, and angiogram was done on the other hospital, and you can see the still image that here you can see there is pseudoaneurysm of the proximal LAD, and you can see here that this cranial and caudal view, you can see that there is one pseudoaneurysm and it's compressing the LAD, and there is critical stenosis of the proximal LAD. If you see at the IVAS, you can start IVAS from the beginning. Please start the IVAS from the beginning. If you start, there is spontaneous echo contrast within the LAD. You can see it's nicely visualizing the, just like we get this kind of picture whether when the patient is having atrial fibrillation and in mitral stenosis and all. And you can see there is thrombosed plaque here. You can see this aneurysm get thrombosed here. Now you can see here clearly, and there is tight, very tight stenosis at the proximal LAD. And look at the LMCA. And though the LMC has minor plaque at the distal end, you can see there is distal end and ostial LAD has some minor plaque. Now you will get that in LMCA there is plaque fissure. You can see at about 9 o'clock position there is some fissure. You can see about 9 o'clock position there is plaque fissure of LMCA, though the LMCA was not very much critical stenosed in this case. So the clinical decision in this case, this patient was referred for CABG, and they denied and they came to me for PCI. So the question is whether you will stent it or not. Then if you stent it, I think we all the interventional cardiologists will stent this case. Then if we stent, then whether we use the cover stent or not. And the next question is whether this case of, but the chance of getting cover stent actually it's not required. Next slide please, because this is already thrombosed. Next slide please. This is already thrombosed. You can see there is thrombosed pseudoaneurysm. This the next question is whether this LMCA plaque has to be covered or not. So I first entered this case. Next slide please. Please run this video. So the Resolute Onyx was taken and the patient was deployed to 318 stent, and please run the video, not running.
This is not a video.
Next slide, please.
This is an image.
Next slide, please. So this patient was stented the proximal LAD. Then the question, then Gary Means suggested that we should cover the LMCA plaque because these fish are already in proximal LAD, that creating the pseudoaneurysm. So we don't know in future whether these fish will get into another pseudoaneurysm LMCA. So we stented this with left main in another stent of 422, and we dilated this stent and with after approaching we dilated with the same balloon, post dilated with the same stent balloon in the high pressure, and you can then run the IVAS, the post IVAS. You can look there is good apposition except in the LMCA. Actually, that time present we planned for further post dilation in later or if required in later setting. So you can see that sec is little bit less than before, though it is still present. There is good apposition distally. And there is some under actually the stent size is less in LMCA because that is why there is some malapposition in LMCA. LMCA was around 4.5 millimeter vessel, but we took 4 millimeter stent, and due to the critical due to that time there's some contrast reaction will stop the procedure. So coming to conclusion, we can take this patient for PCI, and I think this kind of plaque fissure in LMCA when there is another pseudoaneurysm due to rupture of the plaque and causing this kind of pseudoaneurysm, we should cover this LMCA plaque with stenting, and I think I need some guidance from the eminent panelist what to do, what is the right for this patient. Thank you very much for your kind attention.
Thank you, Dr. Patra. It was a great case. And just to summarize that you did a crossover stent into the left main stem, and you extended the stent up to the mid left main stem or up to the ostium of the left main stem?
No, it up to the mid left main, because distal left main there was plaquing. That proximal and ostial left main it is absolutely normal, and the lumen area was more than 6 millimeters square also.
Clearly, as you mentioned, he needs further optimization of the part of the stent which is in the left main stem. You need at least 5 millimeter balloon. I think you will need some short balloons to do the proximal optimization.
Yes, we planned that.
Important. I think you should do it in a few weeks or months' time for the durability of the procedure. I think in the interest of time, if we just move on and then have some discussion at the end of cases. You have to unmute yourself.
Yes, our next presentation is going to be by Dr. Shailendra Trivedi, on primary PCI in a case of LAD diagonal bifurcation lesion. And Dr. Trivedi is joining us. He's the Director of Clinical and Preventive Cardiology at Medanta Hospital in Indore. Welcome, Dr. Trivedi.
Good afternoon to all of you. I'm just sharing my screen. Is my screen on?
Yes, go ahead.
Yes, we can see you.
Okay, so my case is not so complicated as it has been presented till now. It's not left main, it is LAD diagonal bifurcation. And this was done in a situation of acute MI. And we had this 54 years old female who presented to us with chest heaviness, nausea and vomiting for a duration of 3 hours. She was diabetic and hypertensive, and she also had rheumatoid arthritis with deformities. ECG showed acute anterior wall MI, and the EF was 35% when we did the procedure. So the patient consented for primary PCI, and this was the angiogram. You can see the circumflex is clean, and there is a bifurcation lesion of LAD and diagonal. This is the epicranial view. And this is the RCA shot, which shows normal coronary. So at this point, we wanted to decide our strategy. Now, in a primary PCI situation, usually we want to avoid putting a lot of metal inside the arteries, and we would like to get away with single stent. But here, if we go by European Bifurcation Club's recommendations, these are large diagonal, and the lesion length is 5 millimeters beyond the ostium of the diagonal. So we opted for elective two stent strategy. And anyone would like to suggest means what kind of strategy, or shall I go ahead?
Just go ahead, please.
Okay. So we opted for a mini crush strategy, and we have wired both the vessels, LAD and diagonal. First dilated the diagonal, and this was the result after diagonal dilatation. And then we dilated the LAD. This was the post dilatation LAD. Then we put a stent in the diagonal first, and we opted for mini crush strategy. So we have put a balloon in the LAD distal to the diagonal origin, so that we can crush the stent easily. Later on, it may not be possible to negotiate this balloon in the LAD once we put the stent in the diagonal. So we positioned the diagonal stent at the ostium and deployed it. There was some residual stenosis at the distal end of the diagonal, so we dilated it with another NC balloon. And this was the picture after the dilatation. Then we crushed the ostium of the diagonal stent with the LAT balloon. It was a non-compliant balloon. Subsequent to this, the diagonal wire was removed, and we brought in the LAD stent. This was 2.7523 Zines. The previous one was 2.518 Zines. So this was the picture after deployment of the LAD stent. There is some under expansion at the carina, you can see. And then we rewired the diagonal stent. Here, the strategy should be, you should try to cross the proximal struts of the main vessel, so that we can push the metal towards the carina, and the carina is well formed. That's what we tried to do, and we were nearly successful in doing that maneuver, that we crossed through the proximal struts of the main vessel stent into the side branch. Following this, we dilated the side branch using a 2 millimeter balloon, so it went easily. First, we had dilated with 1.5, then with 2 millimeter balloon. And then we did the final kissing into the LAD and diagonal using 2 non-compliant balloons. And final pot was done into the LAD for coming out. So we tried to follow all the steps necessary for optimization of the result. And this is the allocranial view showing good carina and good flows in the LAD and diagonal. These were the final pictures. So the main point was that it was done in a situation where acute MI was there, and we had to put 2 stents, and by using this mini crush technique, we could successfully do it. Thank you.
Thank you, doctor. I think that is a great case. In the interest of time, I'm just going to go forward with the next case. The next presentation is going to be by Dr. Nitin Modi. In left means all's well that ends well. And Dr. Modi is a senior interventional cardiologist at CHL Hospital in Indore.
Good afternoon. I'm just sharing my screen. I don't know what is the issue. Where is the? It's now visible.
Yes, yes.
So my case was a simple case to begin with, but ended with a left main stenting. I'll come to the case. It was a 56-year-old gentleman, non-diabetic, normotensive. He had anti-wall MI, thumb was 1 back, and had ejection fraction around 45%. And this was the angiogram. Angiogram was showing some osteoproximal LAD lesion, some lesion into circumference. I will show you all the views. So this was a lesion. One lesion was in the osteoproximal, another was in the mid LAD. There were 2 lesions. Circumflex was showing mild plaque at the ostia, and some lesion, mild lesion into the proximal LCX. I'll show you. This is a caudal view. Okay. So in this view, I thought there's some space at the ostia of the LAD. Where can I put a stent? So then this was a plan. I was having a plan to dilate the mid LAD lesion, which was having some moderate calcification, dilate with the NC balloon, then dilate the osteoproximal LAD lesion, and 1 stent from ostia to mid LAD with keeping few strips of stents protruding into the left main, which was the plan. So I started the case. What we do usually, the lesion was crossed easily with a BMW wire. We do the sizing with the dark portion of the wire. Then I took another wire into circumflex, because as a routine, when we are doing ostia LAD, we put a wire into circumflex also. Okay, so this was the picture. Then we passed a 2 routine balloon, all were not dilating the lesion. I took a 2x15 NC balloon, but this balloon ruptured. This could not open the lesion. Even we had 2 NC balloons ruptured during the procedure. Then I thought maybe I should take a smaller size balloon to dilate the lesion. So I took a 2x8 mm size balloon. But this also didn't work. The lesion we are not able to dilate. So that time I thought I should take another wire technique, maybe simultaneously 2 wires in the LAD. Another wire may work as a cutting and we may be able to succeed. But again, we failed to dilate the lesion. So this time, this was a lesion, 2 wires in the LAD. We are not able to dilate the mid LAD lesion. So what mistake I thought? I underestimated the calcification in the mid LAD. Maybe I underestimated the LCX lesion. We are having a small center. We are not having the facility of IVUS, OCT. And at that time in the lab, I was not having a high pressure OPN balloon. So we planned the case 2, we planned for next day with a rotablation. So next day we started the case again. And this time routine, pass a routine wire, then exchange with a rota wire with the help of microcatheter. We did a rota with a 1.5 mm burr. The lesion was very tough. It was not easily gave up. But after a few runs, we were able to negotiate the rota. This was 1.5 bar. Then we took a, this was a shoot just after the rota. Then we took a 2 into 15, another NC balloon to dilate. You can see the vest, it was heavily calcified. Again, this balloon also ruptured. But before rupturing, it gave way and the lesion was quite dilated. We thought it is now. We see the last few frames of the balloon. They dilated, then it ruptured. Okay. So this was just after the lesion ruptured. Now we are ready to take the stent. We took a 2.75 into 30 mm stent, right, posted from the ostia, and earlier measurement we thought it would cover till the mid LAD. This stent was deployed. Post stenting, there was some heaviness at the distal edge of the stent, but that time we are more worried about what happened to the ostia. So next shoot. Some heaviness was there at the circ ostia. Another angle, but it looks like in this view, it looks okay. The stent placement was quite well, just at the ostia with a slight rotation to left main. Here now, we were worried about the distal edge of the stent. There was some heaviness. So we took another stent 2.75 into 14 because we thought we missed the distal part of the lesion. Or then we dilated it, and the same stent balloon was taken for dilating the whole stent, because earlier we had deployed the stent at a nominal pressure, but we post dilated with the same stent balloon, whole of the LAD. We also dilated the ostia of the LAD with the same 2.75 of the into 14 mm stent balloon. Now, just after dilatation, this was the picture. We had maybe a flag shift, something which has gone from the LAD to the left main. This view was showing clear picture of the circumflex ostia earlier. So we have taken out the balloon and we have done the another shoot. There's some heaviness at the LCX ostia and the slight flow was reduced in the circumflex, flow was there. So first thing came into my mind, better to reopen the circumflex. So I took a 2 into 15 mm balloon and dilated the circ part. And post dilatation, this was the picture. The flow in circumflex and LAD both were there. So at this stage, I thought we had to take care of the circ ostia also. So put a stent from left main to circ. Before putting a stent, I thought the LAD stent is coming, protruding into the left main. So better to dilate the area with a larger size balloon, because otherwise the strut would obstruct with the passage of the stent into circumflex. So I dilated with a 2.5 into 15 mm balloon from left main to the circumflex. We took a 3.5 into 30 mm balloon from left main to circumflex, covering the lesion which was showing around 30-40% lesion was there into the circumflex. So covering that lesion also. So this was dilated. Post dilatation, the ostia which was looking very dirty, now it's better. Now I have to recross the LAD. LAD was recrossed, then the struts of the circ stent which was at the LAD ostia was dilated with a smaller balloon 2 into 15 mm first. Then this is the picture. Then I thought I had to do the final kissing. First I took a 3 into 12 mm balloon to dilate the circ stent which is across the origin of the LAD. With this 3 into 12 mm balloon, I dilated the whole of the LED stent. Then doing a kissing. The kissing balloon in the left main to circumflex was 4×12 and left main to LED was 3×12.
Yeah. Change here.
Was done. Then the final pot of the LED left main with a 4.5×6 mm balloon. This was the final picture. So what I have learned from these mistakes that I underestimated the severity of calcification in the mid-LED, underestimated the circumflex osteal lesion. Rotor ablation should be in my plan from the beginning, and proceeded in almost 2 months, and the patient is fine health. So any suggestion from the seniors and the panelists, what could be a better way for tackling this disease? Thank you.
Yeah, very interesting case, Dr. Modi. I mean, this case highlights a couple of issues that there was a severe calcification in the mid LED and also at the osteal LED.
Yeah.
And secondly,
calcification on the osteal LED was not serious. I think I should go for. So maybe okay.
Yes, and the other thing which we discussed earlier as well, these osteal lesions, if they are true osteal lesions, they more or less always extend into the left main stem. So I think the crossover stenting across the circumflex, if that was the primary strategy, that might save some of the future steps. And secondly, this case is a very suitable case for shock balloon actually. This because you use rotablation. After rotablation, also the lesion was not dilating. And that's what happens if there's a deeper calcium. We call it rota shock sometimes. We use rotablation to cross the balloon and then use a shock balloon. Because you see, when you deploy the stent proximal in the ostium, still there is some restriction. I know you've achieved a great result, but if you would have some plaque modification, that might be another thing which could be done. But obviously, availability of the resources is one of the issue, and you can't plan for everything upstream. So I think. That's what my comments are. I don't know what anybody else has comments.
I am a pass out from SGPJ Lucknow, and my professor head, Dr. Nakul Sinha sir, is there. And whatever I am doing is because of his tech teaching and his blessings there.
I think you are lucky.
Such
a great teacher.
He's there, sir.
So I think, is there any other question from the panelists? Because you're running very and the people are waiting for the next session. We should try to wrap up this session.
Yeah, I think I agree. Let's wrap it up. It's been a great session. We've had some very interesting comments, some fantastic cases. And I think let's continue to the next session. Some of our panelists for the next session are already here. And the next session is going to be on an ode to revolutions in complex PCI. I now hand it over to the moderator, Dr. Nishit Chandra.
Okay, thank you, everyone. Thank you. Thank you, all the panelists. And
thank you, Dr. Gupta. Requesting everyone from the previous session to log off, and for the audience I would request to stay with us. We are merging both the halls so that everyone can see the session at the same time. Good evening, everyone. I would like to invite you all for the second session, an ode to revolutions in complex PCI. I would like to call upon the moderator for the session, Dr. Nishit Chandra, who's Director of Interventional Cardiology at Fortis Escorts Hospital. Dr. Nishit Chandra, I hand it over to you.
So thank you, Shantanu, and let me begin this session, which is the ultimate session, but very, very important session, by thanking Translumina for organizing this very, very informing the BIC web conference for the first time in India. I was told that the last day, about close to 2,000 participants around the world have joined. So this has become, I think, the new normal, and this is, I think, will be the way forward for collaborating, exchanging, and learning from each other's cases. So this will be a very, very interesting session. It will be all the luminaries in the world of intervention from India are here. And let me first introduce my panelists. It's an august team of panelists. I have with me my teacher and mentor, Dr. Professor Nakul Sinha, who is now spearheading the newly commissioned Medanta Hospital in Lucknow. Welcome, Dr. Sinha. Now, Dr. Sanjog Kalra, Sanjog is here. So, and welcome, Sanjog. Sanjog is the Chief Interventional Cardiologist and an enthusiast in chip cases and mechanical circulatory support. And he's from Einstein Healthcare, New York, the epicenter of the pandemic. Welcome, Sanjog.
Thank you.
Dr. T.R. Muralidharan. Dr. Muralidharan is head of the Department of Cardiology from Ramachandran Medical College Hospital in Chennai. Dr. Muralidharan, welcome, Dr. Muralidharan. Now I welcome Dr. Heramat, who is the director of Ruby Hall, the famous Ruby Hall Clinic in Pune, one of the initial centers of interventional cardiology in India. Dr. Heramat, please. Welcome, sir. Now I welcome Dr. Sengotuvulu. He is a senior consultant interventional cardiologist and a very, very active participant in the interventional field in India in academics. And he is pioneer to a lot of new cases and techniques. He's from Apollo Hospital, Chennai. Dr. Sengotuvulu, welcome here. And finally, I would welcome Dr. S.M. Ashraf from Kannur. He is heading the Department of Cardiology in Government Medical College, Pariyaram, Kannur. Dr. Ashraf. So welcome you all. There are a few housekeeping rules before I begin, that once you start your presentation, please share your screen and unmute. And after the presentation is over, unshare your screen and mute yourself. And so let's start with this. The first topic is a very, very important topic, and this will be taken by Dr. Tejas Patel, who is the chairman and head of the Department of Apex Heart Institute, Gujarat, Ahmedabad. And he will be talking to a very, very interesting technique, which is more relevant in this pandemic. How to do a robotic and what is the current status and future of robotic PCI. 5th of December 2018, he was the first in the world, while sitting in his hospital, Apex Hospital, he did a first robotic PCI 32 kilometers away in the ashram. And this, in fact, has become the landmark in the world by showing the world that yes, PCI can be done remotely. And in this pandemic, when people are locked down, we can, in fact, enhance our skills and impart our skills to people sitting miles away. So I invite Dr. Tejas Patel for taking us through this interesting journey. Dr. Tejas Patel, please. Please share our screen, sir.
Yeah. Good evening, everybody. Am I audible and seen?
Yes, very loud and clear. Please.
So I will be speaking on robotic PCI. It is new for India, and of course, it is new for the world. Although, it has begun since 2005 on a very modest note. The first thing is, when we talk of robo. Many interventional cardiologists will say that I don't need a robo because anyway, I can perform any PCI with this pair of hands. Yeah, you have excellent pair of hands, that is fine. You have a very sharp brain, that is fine. But then robo, in whichever field robo has entered, it has created its unique space, and I am going to discuss that. This was actually Henry Ford, when he created his first motor vehicle, he was asked by the media that, have you ever asked your customers? And this was his reply. If I had asked my customers what they wanted, they did have said a faster horse. So, we have to keep our mind open for any new technology. And I think most of the wise interventional cardiologists follow these things. This is how a robotic console is kept away from the patient, maybe 5 or 6 feet away, or you can keep it even if you have a big room by the side of your cath lab, you can keep it over there also and work. On patient side, you can have maybe one assistant who is preparing everything and fixing the robo, and then the person can also come and sit in the console with the primary operator. And this is how a robo cassette is fixed on a robotic arm, and guide wire, balloon, stand, everything can be loaded. And then the cassette is now loaded, and this is how it looks. This is me with my partner Sanjay, who is sitting by my side, who has prepared everything. And this is how we work. There are 3 knobs. One I am using is for the balloon and stand to move forward. The middle one is for guide wire movement. And the green one is for guide catheter. So this is a GRX system, upgraded system with a good amount of artificial intelligence, including ROR and other facilities. And this is how this acute MI was done. This is simply, and then, you can just come out and remove everything. So this was before and this was after stenting. First robotic PCI with Colfax GRX was performed at Apex Heart Institute outside US, that is from the whole of Asia, Europe, Australia, New Zealand, and Africa. This was the first installation at my place. Why I installed it? The only reason or logic I had was that I want to work with robo, and robo, wherever it has entered, it has always had its value. The program started on 5th of December 2017 when we performed first robotic PCI at Apex Heart Institute. And this is Joe along with me and Sanjay. And we finished it. We had a good media buzz for that. And not only in this country, even in US. And this was the first case what we did. And then we started doing, more and more difficult cases. Within 2 months in 2018, in the month of February, we had TRICO. In 2 months' time, we were done with 75 cases. And this time in our course, this is an international transradial course, we did 4 live cases of robotic PCI and showed to 450 interventionalists from India and across the world. Yes. Then our journey continued. By May 2018, we were done with 150 robotic PCI. The Chief Executive Officer, Mark Tolan, visited us, and we finalized at that point of time, first in human distant telerobotic PCI site. Distant site was the Akshardham temple, which is one of the iconic places in India, in Gandhinagar, 32 kilometers, that is 20 miles away from Apex Heart Institute. and patients were to be lined up at Apex Heart Institute. By the time we continued doing, we were becoming more and more comfortable addressing more and more complex lesions using robo. These were few of them, like a complex type C lesion. Here you can see a bifurcation with wire, single stent in this case. This was acute MI. And so these were the cases we were doing very successfully, and we were becoming more and more comfortable. Even we started embarking upon this type of chronic total occlusions using the robo, and we were addressing everything, slowly but surely, and becoming more and more comfortable. We are widening our horizon. This was an ISR case in the venous graft to PDA, and no reflow, we addressed that. And this was a case which looks to start with very simple. Again, the complications, we never switched over to manual, and we continued with robo. Here we had created a spiral dissection which we fixed, and there was a small aortic root dissection which was managed conservatively. So in the journey in month of August 15th and 16th, I went to Mayo Clinic, and I was a part of animal study of distant telerobotic stenting along with my friends at Mayo, Rajiv Gulati, Malcolm Bell, Macron Elliott. And this was on the second floor of the major main hospital building. We were sitting, and the animal lab was on the 17th floor. And we did several interventions on peak using the internet bandwidth, and we were able to maneuver our wire and stent and balloon everything so well. And then the D-date came. This was December 4th, 2018. We were done with 276 robotic procedures, 17 crossover, 15 hybrid, and 2 technical failure. December 5th was the D-date where I was there. I was sitting on the remote side at Akshardham. We created a console in a room, the conference room, and my partner Sanjay with my team was at Apex Heart Institute. And we had a geo internet connection. The bandwidth needed was about 40 Mbps, and we were having around 90 Mbps speed, so we were very comfortable, almost 95. 5 cases one by one were addressed on the same day using this distant telerobotic. And this, we started with a ritual in the temple. The priests made us go through those rituals. This was me along with the CEO of the company. I sat on the console, and I could see my team at Apex Heart Institute in the cath lab. You can see these 3 nodes and everything, and I can see the blood pressure, monitor everything. We had an auditorium just 50 meters away from this room, and almost 100 guys from electronic and print media from India and abroad were also present there, because this was a historic event. This is me along with my friend Samir Pancholi, who flew from US. We were sitting at Akshardham in the conference room, and here you can see Sanjay along with Yash and Rajni and my team. They were preparing, they were fixing the patient on robo, and we did the procedure. And this is a 1-minute clip of that first case, the historic case, the first in-man intervention. After our chief minister and everybody was present, because it was a big event for the state of Gujarat and of course for India. And very confidently we did. And I was talking, my friend Samir Pancholi was sitting in the auditorium and moderating the case along with the journalists, and Sanjay with the team was at Apex, and I was doing bilateral communication with both the sides. This scene in the auditorium, the screen you can see, and other small screen I am seen, and I'm working on the first case, LED critical block, which was fixed, ballooned, and after ballooning, we stented the lesion, and we checked the end result. Everything looked like as if I am working in the cath lab and maneuvering my wire, balloon, and stent, everything. I could not feel the leg, and this is how that case was successfully done. And after doing that case, we had a press conference, and following press conference, we continued and finished other 4 cases. So 5 cases were done. This was the first tight mid LED case. You can see the lesion and the result. This was the ostial LED tight lesion and the result. The third case was again LED result. We selected type A and B1 lesions because it was a proof of principle study. This was a tight circumflex, and this was a distal PDA. All 5 cases were done without any glitch, and we were successful doing it. These were the data of the patient. One patient was 84, otherwise the patients were in their 50s. We didn't take much time. In less than half an hour, each procedure was finished. And these were the radiation data. And this was a joyous moment. Everybody enjoyed. And we got some good press. And then ultimately we were able to publish this in Lancet Clinical Medicine as original first in human study. Our journey continued, and then there was always one criticism that benefit to the operator is known, because the operator does not come in the vicinity of the X-ray tube. But what about benefit to the patient? This is very important, because if you don't show benefit to the patient, neither the hospital management has any interest, nor insurance company, and nor even the patient. Why patients should pay anything extra for any technology, how sophisticated it may be, which does not offer any benefit to the patient. So, benefit to the operator, as I told, is well known. Another benefit, only benefit to the patient was the number of stents. There were lesser number of stents because of the precision and accuracy in the measurement. However, nothing major. So we thought of studying it. And we collected 1-year cases up to the December 2017 to March beginning 2019. There were 996 patients out of 1,022 patients. We were qualified. We did an extremely careful and meticulous propensity score match analysis of a large cohort, traditional PCI versus robotic PCI. My friend Samir Pancholi helped us doing all this statistical analysis, and this was the unadjusted co-primary outcome. The co-primary outcome was the radiation, air curve dose area product, fluoroscopy time, contrast volume, and total procedure time. Everything significant, but then we did propensity matching and selected 280 cases in each arm, traditional versus robotic PCI, and propensity. After doing that, we could see significant difference as far as the reduction in radiation is concerned, that is air karma and dose area product reduction is concerned, to the patient with robotic PCI. Fluoroscopy time, not statistic, it had a little bit trend towards reduction, but not significant statistically. Contrast volumes almost the same. Only the procedural time was significantly longer in robotic PCI, around 10 minutes longer. But that was because we have to prepare the cassette, and with time we are even becoming better and better. So this comes to your mind, how come patient has a lesser radiation? And we have discussed, this paper has been published in Circulation Intervention recently on May 5th, and we have discussed this thing, that we kept the table height from the tube quite high, keeping Alara principle in mind without any, compromising the quality of the image. Because you keep, table away from, more and more away from the tube, the radiation to the operator is more, but here the operator or nobody is standing there, we are sitting there. So we took that advantage. Secondly, most of my runs, the angiogram wiring and then angioplasty standing, except for pre and post, were done on fluorosave because there is a huge screen and my eyes are only at 1 to 1.5 feet distance from the huge screen. So everything is seen so clearly that you don't have to do many cine runs. And this was probably, another important reason for one which we are studying again, and maybe our new paper will be on that. So this study added that the air karma and dose area product was significantly lesser in robotic PCI arm as compared to traditional PCI. Of course, there was some increase in procedural time, but this was not very much. So what is the future of distant telerobotic stenting? Primary PCI at remote location, there are so many remote places where the senior operators don't like to settle. And there are some young guys who are just after passing, go there and they work. And many times very complex procedures, they want to shift the patient to the higher side, higher centers. And during shifting, the patient may suffer morbidity or mortality that can be prevented if you have a trained staff who can fix the patient on robo. And another important application which is emerging is acute stroke management at remote location. So after this experiment, I was involved in another experiment where I first multi-city transcontinental distant telerobotic simulation PCI was done over Verizon 5G fiber on a public internet network at Massachusetts, where I was there, and in Waltham, in Verizon facility. And the simulation facility was in San Francisco, and we did several cases. This is Ryan Madder, and this is me in Verizon facility. And so it worked so well. So within a couple of years, you will see, or maybe 2 or 3 years, you will see the commercial equipment available for this particular purpose, for distant telerobotic. And this is not a sheer imagination, but this is going to be a reality. Cardiologists, after 4, 5 years or 10 years in post-corona civilization, what we say, is moving around with a briefcase, having a console with 5G connection, and he gets a call that there is a patient ready and patient is fixed on the robo. He activates the 5G network and he activates the console, and he's sitting in any corner of the world and doing intervention. This is not simply an imagination, and this is the cutting of a newspaper, Tacoma News Tribune, April 11, 1953. At Pasadena, you see Mark R. Sullivan, San Francisco president and director of the Pacific Telephone and Telegraph Company, said in an address Thursday night. That's what they wrote. Just what form the future telephone will take. This is in 1953. Is of course pure speculation. Here is my prophecy. In its final development, the telephone will be carried about by an individual, perhaps as we carry a watch today. It probably will require no dial or equivalent to see each other if they want as they talk. Who knows, but what it may actually transmit from one language to another. This was an imagination of a telecom type giant in 1953. It took 5 decades for realization of these imaginations. But here, in this era, it won't even take 1 decade, or maybe in half a decade time, we will be getting this. Thank you very much for your kind attention.
That was mesmerizing, Dr. Tejas. And this many thanks for letting us peep into the future. Before I open the house for questions, I just have this question. In the resource limited country like India, what is the future for this very high resource technology?
I tell you, this question must have come to your mind when the mobile technology became available in this country. Each mobile was costing how much? It was the price which was significantly high, and every minute talk, ingoing or outgoing, incoming and outgoing, was very expensive. And what is the situation now? So any technology in its initial phase is expensive, but with time to go, it has to become cheaper and more, and that is how it penetrates in common population.
Tejas, very well said. And congratulations. We've been seeing you for so many days. You led the radial revolution, and now you're leading your 5 decades ahead of most of us, I would imagine. So also very well explained, I would say that. Thank you indeed.
Dr. Tejas, congratulations. I think the telecardiology is a real revolution. So, but thanks to you, I think we started the robotic last December. And I think I spent some time with you about one day, I think, in Ahmedabad. And after that, we did a robotic, first time shockwave IVL with robotic. And also we did a long stent, 60 millimeter with robotic. So it's quite interesting. As you said, the more you do, I think the whole thing progresses and you keep doing more and more complex cases.
That's right.
I would like to ask you one important question on the distant stenting.
Mm-hmm.
So what does our law say? Because, you know, telemedicine has so much of problems, challenges when you consult, even do an online consultation. But when you do a procedure from a distant side, so how did you get the permission? Did you get the permission?
Yeah, I got my study cleared by my institutional review board. And then, you know, I got it cleared through DCGI. I was able to convince them, first of all.
Do you think
let me tell you, we are definitely, we are sitting at the cusp of 2 different civilizations. So we are lucky to see 2 civilizations, like Nile civilization or Sindhu civilization. We are now going to enter in a post-corona civilization where digitalization is going to be the way of life. This distant thing is going to be the way of life, and people will have to change. People's mindset will have to change. The government policies will have to change, and we have to work on this line, I suppose.
Yes, I hope this happens. Yes.
So thank you, Dr. Tejas Patel. So let me now take this opportunity to invite the next speaker.
Thank you.
And next speaker is Dr. Ronnie Matthews, and he's the head of the Department of Cardiology at Lisi Hospital, Kochi. And he will be showing us the shockwave lithotripsy, how it has made the tackling of calcium easy. Dr. Ronnie Matthews, please. Dr. Ronnie, please unmute yourself. Dr. Ronnie, you have not unmuted yourself. Please unmute.
Okay.
Yeah.
I'm sorry for that. Can you hear me now?
Yes, loud and clear.
Great. So good. I think we had a very interesting talk, and after this interesting talk from Dr. Tejas Patel, let me try and tell you about this new kid on the block, and that's the intravascular lithotripsy. Calcium has always been, one second, let me move this right. Calcium has always been a last frontier for most of us. And I think rocks in the coronaries, as you see on these 2 angios, you can see the calcium, you can see the entire coronary tree even without injecting the contrast, and always been a challenge to us. And I believe this was the last hurdle in coronary interventions which we needed to cross. Of course, we had large amount of devices for this. And with optical coherence tomography, we were able to actually see this calcium. And if you look at from the left panel to the right panel, we found that calcium comes in different forms. Superficial calcium, then there's circumferential calcium, eccentric form of calcium, nodular calcium that juts into the coronaries, then the deep calcium. And each of this needed a different technique to tackle. They were not that easy as we thought. We had rotablation, but sometimes rotablation was not sufficient enough to tackle this calcium. Now, if you look at this particular case itself, we have a nodular calcium there. Look at the optical coherence tomography, and you find a calcium that's more or less a 300-degree arc on the left panel, and with good depth. The lumen is only around 0.9 millimeters, but the thickness of calcium itself is close to a centimeter, and that's truly a thick calcium. Now, if you rotablate this, and we did that with a 1.5 burr, what happens actually is that you do punch a hole into this calcium, and that hole is about 1.5 millimeters. Now, in spite of punching that hole, and despite that, you still have about 500 microns of calcium. Now, this calcium needs to be disrupted before you actually can put in a stent. Otherwise, we're going to have a under expansion, and an under expanded stent, as we know, is a major predictor of adverse events. And this is where shockwave does come in. Remember the rule of 5, we always say, when you have an arc greater than 50% of the vessel arc, calcium thickness greater than 0.5 millimeter, and a calcium length more than 0.5 millimeter, your chance of under expansion is very high, and we need to have some form of calcium modification. The IVL system is relatively a very simple system, and I was also surprised when I initially used it. It just had a simple generator with a connector cable and an IVL catheter. The balloon itself had these lithotripsy emitters, and which actually shocked the calcium. If you look at this on the left panel, that's each emitter. And what this emitter does actually is just gives an electric energy, creates a steam bubble. And this expansion and collapsing of this vapor bubble creates sonic pressure waves. And this sonic pressure wave travels through the tissue. Surprisingly, an effective pressure of around 50 atmospheres is generated on the side of the vessel wall. And this fractures the intimal and medial calcium. Truly a revolution in the sense that if you look at this animation, you inflate the balloon to 4 atmospheres, initiate the shock wave, fracturing the calcium so that you can subsequently go and prevent an under expansion. Create a good bed for your stent to expand. Having shown you all this, let me show you some of my examples. Of course, this were some of the trials that did come on shockwave, which did say that it was safe and effective. Now, this is one of the cases that I initially did. I would probably not take this case if we did not have something like a lithotripsy with us, because there's calcium all around in the right coronary. I mean, right from the mid segment, right to distal. In fact, even wiring was difficult. An emplatzer and then a guide liner, balloon support. You look at the catheter, the shape the catheter takes for just the wire to go inside. And subsequently, we did pre-dilate this lesion. We put an optical coherence tomography to see what, and it was calcium all around, eccentric, concentric, deep calcium. And I think my screen is hanging, but oh, I'm sorry, my screen has stopped. Let me try and go back.
In the meantime, I have been informed by the organizers that a total of 2,783 audience participants have joined around the world. That is phenomenal.
Right. I'm sorry, but I'm going to share my screen now.
Yeah, we can see it.
You can see the screen. Great.
Yeah.
So then we gave multiple pulses with this intravascular lithotripsy balloon. And since this was my first case or my second case, and I realized you need about 10 to 20 pulses to actually crack this calcium. And post IVL pulsation, we do find a decent lumen, and the stents surprisingly went in easily after this, and we got a result that was probably decent. My first experience with IVL, this was in I think end Jan, that made me realize that we have a revolution in our hands called the intravascular lithotripsy. Let me share another case with you before I tell you some of the messages that I wanted to give. So expanding intravascular lithotripsy was this particular case, and that was a calcific instant restenosis that came to us after 8 years. He of course had chronic kidney disease. He has a stent in the proximal RCA and a stent also in the precrux RCA. The troublesome lesion here is the precrux RCA lesion, and in spite of dilating it well with an NC balloon, we still had that particular lesion there. Very stubborn, dog boning. We tried an angiosculpt. Even with an angiosculpt, that dog boning persisted. That was a lesion and persisting, and hence we decided that we're going to rotablate that. So we did rotablate it with a 1.5 burr. I was a little skeptical of taking a 1.75 burr because I realized that there is a stent inside. This was before the IVL actually came into the market. This was sometime in November or December. So after the rotablation burr, we still had that dog bone. That's what it looked like. So we did a optical coherence tomography to see what exactly was going on. And if you see this, there is calcium at 2 o'clock and 3 o'clock within the stent. So it's not an under expansion of the stent 8 years ago, but it's neoatherosclerosis with calcium within this particular stent. You can make that out here, right again here, between 3 o'clock and 2 o'clock position. Calcium remaining there, very stubborn to dilatation, to an angiosculpt, and to a rotablation. So at this point, what we normally did is we thought we had the best result possible and we left him. The reason I'm showing you this is to show you an under expansion is a problematic thing, because 4 months later, he did come with unstable angina, luckily, and this is what we see. We have ISR proximally 2, but distally, we have that under expansion causing a stent thrombosis. That's what we made out on optical coherence tomography. If you see as his run goes on, you see that calcium there, and you see a distal part, extensive thrombus around the under expanded stent. So that's a problem that you do find when you have calcium and you leave an under expanded stent over there. So this time we had this, as I said, the new kid on the block, and that was the intravascular lithotripsy. And we gave a number of pulses, and we were able to get a crack on that calcium, and subsequently a high pressure balloon opened it easily, could put a good stent inside, and we got a good result. And if you look at the lesion, it's expanded. That was what the OCT looked like before we did the IVL and the stent in. Look at that eccentric calcium on the lower panel with an MLA of 2.93, which expanded to the decent 7.44 millimeters minimal stent area, exactly at that area of calcium. So undilatable calcific lesions are an Achilles heel, and the stent expansion, as I said, was a major predictor of MACE. So intravascular lithotripsy did help us in improving MLA in this particular lesion. Now, this is another case in which a rotablator assisted an intravascular lithotripsy. If you see this calcium in the proximal LAD, we initially were not planning to use a IVL. We thought just a good high pressure balloon would do. But then we realized that a 1.5 balloon was going into difficulty across the lesion and that was not dilating. And at that point, we went in with a rotablator and we created a channel across that with a 1.5 rotablator, creating a sufficient channel for us to go and dilate. But when we did the optical coherence tomography, we did find that there was quite a thick eccentric calcium over there. And it's pretty big. The rotablator has punched a hole of 1.4 millimeter, as you see there. Quite a perfect round rotablated lesion there, but a huge eccentric calcium of more than 1.5 millimeters over there. So at this point, we thought if we go with a stent, we're not going to get a good expansion. We did a IVL balloon, tracked easily. So another point, if your OCT catheter goes inside or after a rotablation, IVL tracks very easily. And we gave a pulse, got a good result, and the stent did deploy extremely well in spite of an eccentric calcium. So that's my last message to you. For a tight calcified lesion, an IVL balloon is not likely to cross because it is bulky. So rotablation will help the IVL cross the lesion. IVL helps breaks this and helps expand the stent to an adequate size. So these were some of my cases that I wanted to tell you about this new revolution that we have of shockwave to modify calcium. Thank you for
So thank you, Dr. Ronnie. And let's have a quick comment from Dr. Sanjog. Sanjog, you have been involved in chip cases. So let's have a quick comment from what is the state or what is the place of IVL in your cath lab?
Thanks very much. Yeah, those were beautiful cases and optimal demonstrations of this technology. I think that I agree with Dr. Matthew in that IVL is truly here to stay, and it's not just available and functional in the coronary space, but also in the peripheral vascular space. And so what it is allowing is us to tackle some of these otherwise difficult lesions where the technology that we had previously was good, but not great. There was a case that we did a little while ago where we had 3 layers of underexpanded stent in the left main and a guy with an EF of 30%. The iliacs were horribly calcified and we couldn't get a hemodynamic support device up, knowing that we would have to have a high pressure balloon inflation done in the left main for an extended period. So we used IVL to take down the calcium in the iliacs, deliver a long sheath, deploy a support device, and then used high pressure ballooning and in fact also a coronary lithotripsy device to be able to get excellent expansion. So it's an example of a technology that is helping us deal with problems that we recognize, but that we have never had quite perfect technology to deal with before. I think the future of this technology is going to be getting it more widespread and then making it easier to deliver. There are fundamental issues with the technology that make it more challenging to deliver just because of what it does. And as you know, as Dr. Patel pointed out earlier, technology iterates. It gets better and better with time, and this is a company that has legs. So I congratulate you on those great cases and the use of this technology. I look forward to more.
Dr. Strati, your views on this? Please unmute.
It's a great technology, as I see. I said yesterday that we still don't have it. We plan to have it in the next few weeks. I have only one question. Does this technology modify the vessel wall response at follow-up? Are they studies, OCT studies, angiographic studies? What's about the muscle cell reaction to this technology?
Yeah, I think that's a very good question, but I do not have an answer to that. I do not think we have an OCT long-term follow-up of these cases. All that we know is the acute results are brilliant with no short-term effects. And I think we must point out over this, as far as compared to a rotablator, We do not have slow flow. We can do it in hemodynamically unstable patients with no risk of perforation or dissections. But as you said, a long-term result is not known yet.
I think we have enough data on the cross-sectional area that is achieved at the end of these technologies. And that can be correlated with a good long-term results. So putting it together, I would presume that you would get a good long-term result.
I think in response to Adnan's point, though, I think he has a very valid and very important question that he's asked, because we assume that the minimal stent area is the only predictor of adverse outcome in, or one of the major predictors of adverse outcome in these types of cases where we've modified plaque. And we know from some of the in vivo and in vitro data that the deeper you implant stents into media, the more of an inflammatory reaction you get, right? So the question becomes, if you're delivering electrical pulses, if you're going to induce an inflammatory reaction that is similar, different, or not at all. And I think really there is no substitute for good follow-up and data in that regard.
Thank you, Sanjo. So now let me invite our next speaker, Professor Adnan Kasrati, and he will be speaking on a very, very important topic. We have the polymer has been the bane of the stenting, starting from Cypher, Texas with a durable polymer, then came biodegradable polymers, and now there are certain stents which are polymer free. So he will be taking us on a journey from a durable polymer to a polymer free BAS. Dr. Kasrati has been, he's the head of the department of German Heart Center in Munich, and he is the principal investigator of ISAR series of trials. Dr. Kasrati, please, screen is yours.
Are you seeing my slides?
Not yet.
Not yet, okay.
Yes, we can see.
So, are you hearing me?
Yes.
Yeah. Dr. Chandra, first of all, thank you. And I have to congratulate you for the great job moderating this excellent session. So I am amazed. Yesterday and today, so thank you very much for your work. So don't be surprised. I will focus on during my talk on the work done in the German heart centers about stent technology development. So all of us, we know that the first stent came or was implanted in 1986 by Dr. Sigwart and Puer. And you see what kind of primitive device was at the time. For many years, there was some work done to improve the design of the stents in the sense to improve the procedure results. But very few people thought that the design of the stent would have an impact on the long-term results. We started to work with the stent design in 95, 96, and we saw at 2001, we published the ISAR stereo, the first ISAR stereo trial. We were so interested to see whether the strut thickness or the metal amount was relevant for the long-term results of stent implantation. And this is the first randomized studies with 651 patients. You have to imagine at the time, there were no large trial as they are today. So 651 patients was a large trial. We compared two kinds of stents with the same design, with the same architecture, but with the only difference laying in the strut thickness. There were two multi-link stents, one with 50 micron and the other one with 140. And you have to think that 140 micron was the first Cypher stent. So this was the strut thickness of the first Cypher stent. What we saw with this study was a big reduction, a great reduction in restenosis rate, angiographic restenosis rate, and target vessel revascularization. This was the first study to show the benefit of reducing the strut thickness. And you know now that the thin strut stents are the standard technology in stent field. So as I say, as I said, less metal was our first effort to develop stents with less metal in order to improve the long-term results. And the second interest was also to look which was the best surface of the strut to achieve good results in the future. We thought, first of all, it was conceivable that a polished stent would have the best results, and that's why we started to plate the struts with gold. Gold was a very good metal, and we expected to have good results with this plating, but we were disappointed to see in one randomized trial with more than 700 patients to see that the MACE rate was much higher in those patients who got the gold-plated stent. And what we saw in an observational study, we did analysis of all our stent patients, and we saw that the patients with multi-link had the best result as compared to other patients that did receive other kind of stents. Multi-link, I said, it was the strut thickness, but another quality, a property of the stent was also to be the less polished stent as compared to the other stents. So you have two extremes, the less polished stent with the best results and the best polished stent, the gold-plated stent with the worst results. So we were interested to know which is that a role for the stent polishment in the long-term results. At the same time, we were aware of some experimental results done in the lab of Palmas. He was able to show that the strut with a rough surface improves endothelialization. It was thought at the time that the rough surface helped the endothelial cells to jump and to cover the stent. At the same time, there were also another study showing that surface porosity was also associated with less neointima development. That's why we want to know what is the impact of the strut surface in patients in clinical settings. And we did a small study at the time, 200 patients only, and compared in a randomized way microstructure surface with polished surface. You see here also the microscopic view of these two devices. Both were the same stent, but the only difference was the strut surface. And you see that we were able to see with 200 patients relevant reduction of restenosis, although the result was not significant because 200 patients were not able to give this significant result. On the other side, at the time was also the time of emerging drug-eluting stent technology. And we saw in this property of the surface the ability to increase the drug reservoir capacity. It enables also reduction of the polymer quantity. It enables also excellent performance of polymer-free drug-eluting stents. And you know that several test manufacturers have adopted this technology, like Translumina, Brown, Biosensors. 2002 was also the year in which we were faced with the good results of drug-eluting stents based on the durable polymer. And I have just shown here the two trials, Taxus and Cypher versus bare metal stent trials, that showed a dramatic decrease in the restenosis rate with this new technology. So we thought at the time, 2006, 2007, there were several signals that the drug-eluting stents were associated with late stent thrombosis, and the polymer was also accused to be the main factor causing this complication. That's why we thought that the biodegradable stent, polymer-based drug-eluting stent technology would have benefits in this sense, because the biodegradable polymer are there only for a few months and not after that. So with that, we hoped to decrease the risk of late stent thrombosis, which was associated with durable polymer drug-eluting stents. You see here the microporous surface of the stent, which is done more polished if covered with the polymer and the drug. So these are the results of the release kinetics. You see here the polymer-free sirolimus-eluting stents we developed in our laboratory, and it was a very quick release kinetics without the polymer. And here, with the use of biodegradable polymer, you see that the kinetics, release kinetics is slowed down. On the other side, you see that the biodegradable polymer was able to increase the concentration of the drug in the tissue. There were also animal studies done after these release kinetic studies showing that the inflammation with biodegradable polymer was increased as compared to the bare metal stent, but was not relevantly increased. We did a proof of concept study with 605 patients at the time, the ESA-TEST3 trial, and after that we went on with the pivotal trial, ESA-TEST4 trial, which was a trial with 2,603 patients with de novo lesions, and we used the biodegradable polymer drug-eluting stents, or the Yukon Choice PC, in India, and we compared it with durable polymer drug-eluting stents. At the time, we had available in our lab Cypher and Science. We pooled together in one arm both of the stents. The primary endpoint was 1 year MACE, but we were able to see also 10-year results, and they were published in Circulation. You see the results here regarding MACE at 10 years, and there was a dramatic reduction of MACE as compared to the Cypher stent. It was not surprising, and everyone knows that the second generation drug-eluting stents are much better than the first generation. And you see here very good results, comparable result between Science and the Yukon Choice PC stent up to 10 years. Here is the all-cause mortality, and this is the first study showing the decrease in mortality with second generation drug-eluting stents as compared with first generation drug-eluting stents up to 10 years. Stent thrombosis, you see the numbers here, 3.7% with Cypher, not surprising, but you see that the best results were achieved with the Yukon Choice PC, 1.8, 2.5 with the Science stent, no significant difference, but numerically, the lowest number was achieved with the Yukon Choice PC. What we saw in a serial angiographic study was very interesting. We had more than 1,000 patients having two serial angiographic follow-up studies at 6 to 8 months and 2 years.
ऐसा है कि रिपोर्टें जो हैं वो करीब ठीक ही हैं, लेकिन अभी तक प्रॉब्लम क्या है, उनको दिक्कत क्या है?
Dr. Praveen, your voice is audible. Please mute your. Sorry.
And so we looked at late lumen loss at 6 months and 2 years with 3 kinds of devices, with Taxus, Cypher, and the polymer-free sirolimus-eluting stents. No polymer at all, no biodegradable polymer at all. At 6 months, you see that the best results were achieved with Cypher. No surprise at all. Cypher was much better than Taxus. And the durable polymer Taxus had the same late lumen loss as the polymer-free sirolimus-eluting stents. But the beauty of the study was to show that as both durable polymer-based drug-eluting stents went on losing in lumen between 6 months and 2 years, the polymer-free sirolimus-eluting stent offered a very stable results in terms of late lumen loss. So we thought the best polymer is no polymer at all at the time. And that's why we looked what was the reason for the not very good results at the beginning for the polymer-free. And you see here that the release kinetics, if the stent has no polymer, is much quicker, much faster than with the polymer. And also the late lumen loss, as shown here, it is for the polymer free was much higher than with the biodegradable polymer, with the durable polymer sirolimus eluting stents. The problem was how to achieve this slower release kinetics of the sirolimus without the use of the polymer. So we went through testing several substances, and most of them were lipophilic substances in order to allow the slowing down of the release kinetics. And we found propofol to be very lipophilic. On the other side, propofol was associated with the best results in the area of PCI, as you see here in this study published in New England Journal of Medicine. And this was practically the only oral drug study being able to reduce restenosis at the time. So for us, it fulfilled two goals. One, it is lipophilic and it can slow down the release kinetics of sirolimus. And secondly, if fortunate, if lucky, we might have also this extra effect of propofol. We looked at the release kinetics of the drugs. You see that sirolimus from the biodegradable polymer base is here in yellow and orange, and the two drugs here, propofol and sirolimus, have the same release kinetics with the stent. We looked also at animal studies, looking at the inflammation caused by this kind of device. It was very, very low, very comparable with bare metal stents. We did, even in this case, a proof of concept study, but it was large also. It was with more than 1,000 patients, ISAR test 2, before going to the largest studies in the drug-eluting stent with more than 3,000 patients. It was an ISAR test 5 trial, which compared the polymer-free drug-eluting stents with two drugs, with the sirolimus and propofol. And now this stent is known in India with the Vivo ISAR name. It was compared with, at the time, it was a standard second-generation drug-eluting stent, that's a sirolimus eluting stent with a durable polymer. Here also, 12-month clinical follow-up was the primary endpoint, but now, and it will be published in JACC, we had also the 10-year results from this study, and you see here the MACE rate up to 10 years, no difference at all between the durable polymer and the polymer-free Vivo ISAR stent. Look, that it's very interesting to see that most of the MACEs, if you have it had the first slide, is caused by mortality. So you from 0 to 10 years here, you have a mortality rate above 30% for these patients. They are old patients, so you have to think about it, because this will be the major driver of the MACE in this period of time. But even here, you see a very good numerical results with the Vivo ISAR polymer-free drug-eluting stents. So it's not significant, but you can look at the 9% decrease in mortality with this kind of stent as compared with durable polymer drug-eluting stent. Stent thrombosis up to 10 years, very, very low for both stent platforms, 1.6% for the Vivo ISAR polymer-free drug-eluting stents and 1.9% for the sirolimus eluting stent. So if I have to make the summary of what we had done in this more than 20 years, I can say that both drug-eluting stents developed as part of the ISAR DEST project, the biodegradable polymer Yukon Choice PC and the polymer-free Vivo ISAR, as compared to other contemporary devices, offer a technology with the strength of almost 25 years of research focused on refinement of strut thickness and surface properties, refinement of in vitro release kinetics of active drug by eliminating the polymer, optimal vessel wall reaction in animal models, step-by-step increase in sample size up to the largest randomized clinical trials against the best of the class durable polymer drug-eluting stents and worldwide longest follow-up of efficacy and safety. Thank you very much for your attention.
Thank you, Dr. Castrati, for taking us on this journey of polymers and stent coatings. Can I have a comment from Dr. Raj Tayal, please? Dr. Raj.
Thank you. That was truly fascinating and very important to kind of understand both in terms of past history and in terms of what the goals of therapy are and where we're aiming to go to improve safety and efficacy for all of our patients.
Any other comment? Dr. Ashraf?
I have a question.
Dr. Sanjog, yeah.
I have a question for Dr. Castrati. So I've seen some newer stents coming out with nanopolymers that rapidly recruit albumin to the struts to reduce likelihood of stent thickness. And then these polymers are also rapidly degradable with TLR rates that are phenomenal for a bare metal stent, 4 to 4.2% at 1 year. Where do you think those types of stents will fit in when you've got total endothelialization or 98% endothelialization on scanning electron microscopy in 2 weeks versus biodegradable DESs, which probably have a better outcome ultimately long term, but are quite comparable, at least in the short term?
So for sure, I don't think that the journey is ended here with drug-eluting stents, and there are several technologies or technological development that may improve the results. I have only to highlight here regarding our studies, we have always based our studies on angiographic follow-up. So the data shown here, which are for sure with the TLR higher than what you mentioned about these technologies, has more to do with the way we follow up the patient than with stent technology. But at the beginning, we wanted to be sure about the possibility to analyze in a correct way the efficacy of the devices. Although this is not the routine practice, but for studies, we still think that angiographic follow-up, even with OCT now, is the best way to investigate the vessel wall reaction to new drug-eluting stent technologies. And I think that what you mentioned, there are some ways. We are working now with new drugs that inhibit the muscle cell proliferation. So we don't think that we have still achieved now the best of drug-eluting stent technology.
Thank you, Dr. Castrati. Now, there is a change in sequence if Dr. Tayal permits. Dr. Praveen Chandra has to actually rush for an emergency. So he has requested me to, if Dr. Raj allows, so he can proceed his talk before Dr. Raj. Dr. Raj, will you permit Dr. Praveen?
Of course, no problem.
So let me invite Dr. Praveen Chandra. He has been my colleague and he's now become the chairman of Medanta Cardiology, spearheading the Medanta Cardiology scene. And he's now very active in structural heart and TAVI also. Yesterday also, I think he flown to Mumbai in a chartered plane for doing a TAVI in an emergency case. But now today, this talk is on plaque modification using ultra high pressure plaque modification device. So Dr. Praveen Chandra, the screen is yours. Instead of saying floor is yours, now I have to say screen is yours.
Interesting. So thank you, Nishit, and thank you, Dr. Tayal, for accommodating. In fact, let me tell you, actually, I'm not rushing for any, let me just, be absolutely forthright. I'm not rushing for any urgency. I'm just rushing for another webinar, let me tell you frankly. So this is the age of digital technology. And so can you see my screen now?
Yes, you can. We can see.
Why it is not coming up?
Can you make it bigger, Dr. Praveen?
Yeah, is it? No, I think it's full screen now.
Okay.
Can you see that?
Yeah,
yes, we can see that. We can see that.
Okay. So I've been hearing very nice presentations, and of course, Dr. Castrati is
one of the foremost people in the field of interventional cardiology, and I think he has given the data to interventional cardiology nobody has given, in this day and age. And so we are very small in front of him, but certainly I will try to put up the data which we have in ultra high pressure inflation. And I don't know whether he has any role in inventing this technology, but certainly I'm sure he has used a lot of it. And many of my colleagues sitting here have used these ultra high pressure balloons. Dr. Hiremat and Dr. Kalra and Dr. Nishit, everybody must have already done so many such cases. So basically, just to recapitulate, and it's basically a double layer of double power coat the polymer, and here you can see that it has the technology has been improved so that it doesn't become too high profile as it used to happen in the past with the high pressure NC non-compliant balloons. And so this has a reasonably good entry profile. And now one of the smallest one is the 1 millimeter balloon, which is quite good for entering into the CTO channels, which are very, very calcified and hard. So what is the use? Where do we require such kind of technology? And many people may say that they don't need such kind of things. They've been doing such angioplasties, as was the point put forward by Dr. Patel, that any new technology, when it comes, everybody starts saying that probably it is not required. But let me tell you, we have been doing difficult cases, and there have been problems. And these problems happen especially in, if you can see here, calcified, heavily calcified lesions. Resistant, undilatable lesions have been in everybody's practice. I mean, if somebody has done reasonable number of cases, he has to see these kind of problems. And in-stent restenosis, again, issue which is still continuing to be there despite the success of all kind of stents, whatever type you can name. It is not gone. It is still there. And of course, many times, as you also seen, saw in some of the cases, that rotablation was done, still the lesion was undilatable, and the stent could not be placed. So that is one situation. And then post-dilating stents, in situations where the stent is not dilating, again, there is a need for a device which can work here. In many CTOs, you can, may not cross the balloon, the high profile NC balloon. So you need some balloon which is crossable and also dilates these lesions. So basically there is a need. Definitely there is a need when you start doing more and more complex cases, or even if somebody may, have these kind of problems in the very initial cases. So one has to know what kind of devices we should have. So many times we are not able to identify the calcium, and especially, I will say that most of the times we don't use intravascular imaging in routine circumstances, and then there is underestimation of calcium. And when there is underestimation, that leads to a likelihood of improper vessel preparation. And then subsequently, these kind of problems happen: stent under expansion, increased risk of complications, longer procedural time. You may be using 6 balloons, 8 balloons, 10 balloons, and it's not going. And then stent malposition, and more stents may be required if you do too much of handling of these vessels. So we need some device, certainly. And one of the device we heard from Ronnie Matthew, which was the shockwave. And so we have this. This I will say is the cousin of shockwave, but cheaper cousin. So it's good to have it, because you can't use shockwave in every patient. It is expensive as of now, and of course you need something to go in quickly sometimes. So how does it work? It has a controlled growth. So when you go to very high pressures, because many times when we used to go to high pressures, we were very scared that the balloon may dog bone, the balloon may burst, or it can expand a lot. So the expansion here is 10% at high pressures, going up to as high as 40. Expansion is very linear, as you can see here in this chart, that the growth of the open NC balloon when it goes to ultra high pressure is completely linear, going up to 40 atmospheres. And the usual thing which happens with many balloons is the dog boning effect, which is almost that it is up to 35-40 atmospheres. No overexpansion is happening, and hence it is not going to injure the vessel wall. So here you see that in these kind of situations where the drug-eluting stent is not expanding or will not expand, in these cases we can use the open NC balloon to expand, crack the lesion, and once the lesion is cracked, then we can place the stents in these positions. So how does it compare with the existing devices? And so here you can see that the ease of use is immense. You don't have to use any extra gadgets. And of course, the suitability for treating all kind of calcified lesions is certainly there. The procedural time is very low, and the learning curve is not there actually, I must say, except one or few tips and tricks which I will tell you. And there is safety is quite quite high, I must say. And in our experience, and of course the experience which has been published, the chance of having a perforation or a rupture is very, very low. So the dissection perforation events are very low. The acute gain for a better stent apposition is very high, and the inflation time for the lesion dilatation is also very, very low. So ultimately leading to less exposure to radiation, because in contrast to using many balloons, you are using just one balloon and it's all gone. So that is the advantage. And here you see again the studies, as I told you already, that Dr. Strati is the leader of all the studies. And here is the ISR calc study. And this was published in 2019. And it's a 326 patient study where you see that the angiographic success is 97.5%, with 53% lesions which is responsive to group 1, whereas 43% is responsive to group 2. And the high pressure, if we're done in more than 35 atmospheres in most of these cases, with very heavily calcified lesions, and proving to be very safe and effective. So the groups, as I must tell you, here was the 30 to 40 atmosphere, group 1, and more than 40 atmosphere is group 2. And most of these lesions actually responded to either of these pressure strategies. And this study again done with the open NC balloon expansion being done to 20 to 30 atmospheres, where the lesion was not responding to NC balloon. These patients were enrolled, 91 lesions. And here it shows that where NC balloons fail, then open NC can provide an effective and safe alternative for resistant coronary lesions. Another study, so there are studies now available where we can relate to, and this was a study done in the bioabsorbable stents. Of course, they are not there, but let me tell you, everybody's here, and most of you may be knowing that now we have the bioabsorbable stent available in India, which is maybe going to be used in specific patients, in niche patients, and the device has been approved by the drug controller DGCI for commercial usage. However, the absorb stent is not available right now. So in this study also, it was shown that open NC can be used to treat in-stent restenosis pre and post dilatation in these patients where BBS was used. So what are the tips and tricks? Nothing much actually. The only, I think, important one is the use of the wire. So one has to try and use a wire which does not have polymer sleeves, and so most of the times we use the see many times if you go to above 30 atmospheres, it starts sticking on the wire once you are pulling back the balloon. So it is important that from the very beginning you can use one of those wires where it doesn't stick. So that is the only difference. And the sizing is 1:1 for post dilatation, and for any inflation device can be used which goes up to 40 atmospheres. However, there is a device which is coming from the same company which goes up to 55 atmospheres. So one can use that for dilatations going beyond 40 atmospheres. So the only last advice is that, one has one, which is normal with any balloon, you go gradually up. So wherever the balloon, gives way, that is where we have to stop. So if you are using open NC, you just go straight to 40 atmospheres. That may not be necessary. So these are some of the cases. You will see that this is a patient who had a lesion in the proximal LAD, undilated with 3 NC balloons at high pressures, and then we had to use so this is an open NC, and here you can see that this 2.510 open NC goes yields lesion at 30.
Dr. Praveen, your audio is breaking up.
So that is what was required. So that is the common usage which we have. Audio is breaking. Okay. So let me just see. Is it okay now?
Yeah, better.
Yeah. I think there is some internet issue maybe here. So basically, this is the commonest indication, I must say, where one NC balloon is not able to do it. We go straight to the open NC. We don't try to use any other as of now. So this is another page.
You are stuck.
Yeah, it is. I don't know where it is stuck. Okay. Here you see, can you see the image now? That the balloon is not expanding. It is just moved forward. Anyway, it was showing a similar thing, that the balloon is not expanding, the NC balloon, and it is just dog boning, nothing happening. And then we switch over to open NC and it just gives way. So these are many such cases in various locations showing the same thing. And then of course the other issue is melon seeding. In very calcified tubular calciums, you see that the balloon just jumps out. Every time you expand, it just comes out. So this is one thing, which we can avoid when we are using this kind of device. And so sometimes we have to use 2 NC balloons. Go with a 2.5 first, and then again upgrade to a bigger size balloon, going 1:1 once the stent is already in place. So that is the strategy which we use. And these are some of the, these OCT images where you can see that it can really crack the calcium. The fissures in the calcium can be seen once the open NC balloon dilatations have been done. So it is quite effective strategy, seen both clinically and also on OCT examination. And here again you see that the balloon is dog boning and followed by open NC dilatation. So this works quite well, quite predictably actually. And this is the OCT run. In this patient, you will see that the lesion is quite calcium is there at many locations distally, and then of course at the site of lesion there's a whole lot of calcium which is sitting around 70 degrees of calcium. So this is after dilatation with a 2.510 open NC, and then followed by a stent implantation in the proximal LAD. So these were the cases which I wanted to share with you. And this is a post-bypass patient. Very commonly, we have to use a high pressure balloon dilatation to get good results in these kind of situations. So ultimately, we know that when the calcium load is high, the complications will be higher. And that is why we have to use devices which are more effective in treating calcium and leading to better stent implantation. So the DES expansion has to happen. That is without any doubt, without any question. And that can only happen if you have adequate strategies, adequate devices in the lab. And of course, now if this also doesn't work, because we have seen in some patients that the NC has also not worked and very heavily calcified. So we have used three technologies together. The use of rotablation, use of NC balloons, followed by shockwave. So that is, we have seen very commonly now that if the calcification is very, very heavy, 360 degrees, this kind of strategy also might have to be used. So basically, we have to have all these strategies in the lab to take care of these patients. So stent under expansion has to be dealt with. We can't leave under expanded stent, and we have to lead to a better outcome in these patients. So in severely calcified, coronary lesions, as you can see here, this is the study which is being done at this time, comparing the scoring balloon and the ultra high pressure balloon. I'm sure the study will also show similar results, leading to better outcomes. So with this, I think I will stop here, and I'm sure many of you have already used this, so you can share your experiences. Thank you very much.
Thank you, Praveen, for sharing your experience. Can I invite Dr. Nakul Sinha to share his experience about calcium modification techniques?
Well, till now I haven't had the occasion to use the lithotripsy. I mean, we had 1 or 2 cases lined up, but due to this lockdown, it didn't materialize. But I have witnessed, in fact, I've witnessed Praveen also doing it, and some people doing it in some other workshops. So it certainly is good. We just need to understand as to when and where it's going to work best. So I think the algorithms now are sort of getting better defined as to which should be the first, second, and third option in a particular case, and where you are very likely to benefit most at that, because we have OPN high pressure balloon, which has got us out of trouble in many cases. We have used it in around half a dozen cases. But yes, lithotripsy is a welcome addition, and I think it's going to get more and more popular and useful as we go along.
Dr. Hiramit wants to come.
Actually, if you inflate the OPN balloon and you're trying to pull it out, it grips the wire many times. I believe it's nothing to do with the OPN balloon or 2 layers of layer it has. It is with the high pressure. Any balloon you use high pressure, this stickiness is an issue, and the wire can sometimes come out. So I've seen some operators put a buddy wire. So in case if your wire comes out with your OPN balloon, because even if you deflate, you have no control on it. You have to pull it out, and at least you have a wire on the side. So that may be a little extra precautionary, but well worth it, because so many times you are taking so much effort to go down the vessel in a calcified CTO and such areas.
Thank you, Dr. Hiramat. That was a very good and simple tip. So thank you, Dr. Praveen. And now let me invite Dr. Tayal, who has graciously accepted our request. And Dr. Tayal is a very active on Twitter, and he's a structural heart specialist, and I've been following his techniques of brachial axis of TAVI. But today what he will be discussing is the mechanical circulatory device. In India, for us, mechanical circulatory device was only intra-aortic balloon pump. But thanks to Translumina, that we have now access to this unique device. So Dr. Tayal would take us to a journey of Impella, the world's smallest pump, where and when we should use it. What are the pros and cons of it? Dr. Tayal, please.
Thank you, Dr. Tanda, for the invitation and the opportunity. Good morning to all my colleagues here in the United States. Good afternoon to all of you in Europe, and good evening to everyone in India. So I'm going to talk about hemodynamic support, but also in concert with revolutions in complex coronary intervention. So I think one of the most fascinating things that we have in our field of cardiology and interventional cardiology is the rapidity of which things have progressed. From the first coronary intervention performed by Grunzing himself in 1977 to the use of atherectomy, balloon angioplasty, and moving forward onto drug-eluting stents, as well as some of the devices you all have so eloquently highlighted in terms of incoming technologies, all in the name of advancing the field, both in a data-driven fashion as well as improving outcomes for our patients. In concert with the evolution of coronary intervention has been the evolution of hemodynamic support from the first generation of pulsatile surgical pumps throughout axial pumps that were also predominantly surgically placed, now into the axial pumps, which are predominantly percutaneous. However, there are in concert a variety of surgical successors also available. For Impella itself, its approval was first in 2008 here in the United States. After its FDA and PMA approvals, we've seen a rapid escalation in terms of the use of the device, being still split in about a 50-50 portion with regards to use in high-risk PCI as well as in cardiogenic shock. One thing, however, that has remained relatively consistent despite the advent and movements forward, both in intervention as well as in hemodynamic support, has been the prevalence of incomplete revascularization. And this has been shown in multiple studies across decades. And what we've seen is despite data that suggests outcomes are worse, this remains relatively consistent to this day. So in several studies, what you'll see is that the rates of MACE, all-cause revascularization, are all statistically significantly higher in patients that have undergone intervention either percutaneously or surgically, however, not been completely revascularized. So as we've gone through the data, what we've seen is that the overall benefits to hemodynamic support appear to be much more significant when there is more extensive revascularization. And that's been shown both in the literature as well as in prior studies, wherein the patients, quote unquote, with the most to lose also have the most to gain. However, what we've seen more recently in looking at PROTECT 3 data is that when patients receive more hemodynamic support as opposed to having an intra-aortic balloon pump or an Impella 2.5 even, the differences between the PROTECT 2 and PROTECT 3 studies were basically an increased use of the Impella CP device. We've seen a further reduction in adverse cardiac events. And in particular, we've also seen a concomitant reduction in acute kidney injury related to contrast nephropathy. So I just briefly want to go over a case with you all. This is an 80-year-old physician who was retired. He presented with a CCS class 3 angina, had a PET scan, which showed both anterior and inferior ischemia with transient ischemic dilatation of the left ventricle on stress. He was admitted to an outside hospital with a borderline elevation of his cardiac biomarkers, and an echo done, a point of care echo done, showed a reduction in his systolic function to 35%. He was evaluated and transferred to our center. And in the morning when he was seen, of course, he came over on Friday night. His blood pressure was 80/40, and he was now developing CCS class 4 angina. And here is his baseline angiogram. So what you can see is he's got a severely calcified distal left main and diffuse disease that is predominantly calcified both in the LAD as well as in the circumflex, with collaterals filling the distal RCA. In another view, again, you can see how tight his left main is, along with the diffuse disease, predominantly of the LAD vessel, and extending all the way down. And he's also found to have a subtotal occlusion of the mid-right coronary artery with diffuse disease throughout. So one thing that's well known and kind of understood is that the contractility of the left ventricle varies with coronary perfusion pressure. So normal coronary perfusion pressure is greater than 60 millimeters of mercury. However, when this is reduced, you enter this period of hibernation prior to entering ischemia with reductions in LV contractility occurring relatively dramatically. So in standard unprotected left main coronary intervention, you have a coupling of the LV and aortic pressures. So as soon as a balloon is inflated in the left main, where you have a marked reduction in coronary blood flow, you also see concomitant decreases in the systemic and ventricular pressures. In comparison, if this was done in the setting of having intra-aortic balloon pump, support, where you have augmentation of diastolic pressures, you again see a very marked decrease in coronary blood flow and also consistent decreases in the systemic pressure despite having support. The difference with an LV aortic pump, such as an Impella device, is that you have an uncoupling of the left ventricle and aortic pressures with stabilization despite decreases in the coronary blood flow, maintaining hemodynamic stability. So again, if you have an Impella in place prior to coronary intervention, what you will see is that there will be no significant changes in the overall aortic pressure or pulmonary artery pressures despite decreases in pulsatility. So in summary, the intra-aortic balloon pump, while it can be effective, its efficacy depends on the intrinsic support of the heart. So as the heart function deteriorates, so does the degree of support that is provided. So in comparison, what we have here is simultaneously support of the arterial pressure while unloading the left ventricle, thereby causing an uncoupling mechanism, which allows for longer balloon inflation and provides circulatory support even in the event that a complication is experienced. So here you can see we've gone ahead and placed our Impella device prior to proceeding with intervention. We went ahead and did rotational atherectomy of the left main into the LAD, and then stented the LAD throughout, and then went ahead and stented into the circ and across LAD, finished with kissing balloon angioplasty, and then post-dilated it with IVUS guidance, and you can see our final angiographic result. We then proceeded with rotational atherectomy and predilatation of the right coronary artery and achieved a complete revascularization of this patient without hemodynamic deterioration. 6 months later, he's doing well. He's gone to Disneyland before it shut down because of the coronavirus pandemic. And so the point is that basically Impella has been a revolutionary device which has facilitated more complete revascularization and ultimately allowed for improvements in overall outcomes and reduced MACE.
So thank you, Raj, for this impressive overview of the circulatory pump. Now, Sanjog, you have a lot of work on chip cases, and you have been using Impellas and ECMOs. And so where do you find Impella and versus ECMO versus other MCS, mechanical circulatory devices?
Yeah, that's a good question. We're all trying to figure out what the right patient population is on whom to use any real device, whether it's an OPN balloon or a lithotripsy versus whether it's an Impella, a balloon pump, ECMO, or some of the other devices that are coming to market. And I think the explosion in this area of work has really guided us towards a change in our practice to use more hemodynamic assessment as part of our cases. And that's really what guides whether you use an Impella in a particular case or a balloon pump or ECMO or what have you. Hemodynamics allows you not only to understand whether or not you're in a compensated or decompensated state, but how much reserve you have. And there's very sophisticated stuff being done with intra-PCI pressure volume loops to suss that out further. And so as we get better with hemodynamic assessment intraoperatively as well as pre and post, we get better at identifying whether we need a little bit of support. The IBP, Dr. Castrati was here. Some of the ISAR studies showed small growth in cardiac power output with IBP, sort of 0.2, on the order of 0.2, versus a smaller Impella or larger Impella device, either the 2.5 or the CP, where that small study showed cardiac power output increases of 0.4, or if you need something more like an Impella 5. I think in the setting of elective or high-risk PCI, ECMO is largely gone by the wayside. It's really not a device that we use very much anymore. But in the setting of cardiogenic shock, it's invaluable. And that's the other piece of the hemodynamics, is where when you go from a compensated to a decompensated state, where you're now dealing with an individual that has a progression from just a hemodynamic picture to a hemometabolic picture, maybe involving oxygenation issues, then you need something that's going to be able to supply both of the solutions to both of those sides of the equation, the oxygenation issue as well as the circulatory support issue. And that's really where I think ECMO starts to fit in, when you need more very, very advanced hemodynamic support for advanced shock states, as opposed to more sort of sky level C classical shock states where you catch them relatively early and are able to use an axial flow pump type device to treat what is a hemodynamic problem and not a hemometabolic problem.
Thank you, Sanju. Dr. Sangatoglu, what is your view of what are the barriers and what are the challenges of you incorporating this technique in Indian scenario? Dr. Sangatoglu, are you there? Dr. Sangatoglu is neither. Dr. Muralidharan from Chennai, yeah. Please unmute yourself.
For us, the biggest barrier is the cost, sir. That's the biggest barrier. And the second thing is, in India, they have now approved for only multivessel PCI, not for cardiogenic shock. So we are in that thing. So we need to have a suitable multivessel lesion. There only we could use Impella. There are another patient may be in cardiogenic shock, but we may not be able to use it. So that's a licensing problem. So once it solves and the cost comes down, the usage will be higher. Fantastic talk. We want to use. We are looking for opportunity and the logistics to permit, sir. Thank you.
Dr. Chandra, can I add something to that comment just for a moment? And that is that we need to identify the right patients. And we've got a lot of clinical experience. But as we discussed yesterday, every market is different. Every group of patients is different. And every set of expectations is different. And so India now has an honest effort to create their own database with how this pump works and how best it works in their patient population. And analyzing those data honestly is probably the best way forward in terms of getting approval for things that go beyond just multivessel PCI into the cardiogenic shock realm.
Thank you. Thank
you. Your views, Dr. Sanjay Chugh?
Yeah, no, I think it's a useful device, but it's got limitations of cost and, where exactly it's going to fit in terms of an ethical practice is another question. But clearly it's very useful for high-risk PCI and cardiogenic shock.
Dr. Hiramat?
Oh, great talk, Raj, as usual. I think we are in the process of learning which are the correct indications. And I guess once you get to that, the shift from the usual support, which is generally IABP, would probably come. I guess it would take a few months before we settle down on clear indications.
Thank you, Dr. Hiramat. Now we are coming to the last talk of this session, and I must invite my former colleague, Dr. Sanjay Chugh. And Dr. Sanjay Chugh has been the pioneer of heralding the radial era in India. And now he's in fact moving towards the distal radial axis, snuff box axis also. So he has been the proctor for radial for too many students, and he has taught radial all around India and other countries. So Dr. Chugh, the screen is yours. Radial approach making complex simpler.
Yeah, can you see my slides?
No, not yet.
Okay, what about now?
No, not yet.
Slide नहीं दिख रहा हूँ.
Share your screen. Yes, we can see the screen now. Please go ahead.
Okay, so is it visible now? Clear?
Yeah, clear.
Okay, so good evening, and as usual, radial is always at the end. And thank you for not adding, that turn off the lights when you leave. That's how it used to be. So I'm going to talk a bit about standard as well as distal transradial access. Radial PCI, as you know, is basically low cost, serves a large number of patients, and improves survival. As we know, there's enough data now in ACS and STEMI. And because most of our work, for all cardiologists in India at least, is ACS. This is from one of the write-ups I did for Indian Heart Journal. It was my musings in which I wrote, quoting from Atharved, "Do not be led by others. Awaken your own mind. Amass your own experience and decide for yourself your own path. On this earth,
do I stand unvanquished, unslain, unhurt. That's the publication from where I quoted. So coming back to India in 2002, from Royal Jubilee Hospital, Victoria, a dedicated radial center was like traveling back in time. My colleagues in India considered transradial interventions difficult to do and hence unacceptable. One said it was a gimmick and the other called it like driving in reverse gear. And as happens to anything new and different, as happened with Werner Forssmann's first cardiac catheterization or Copernicus's theory that the sun was the center of the universe, radial too faced opposition and suppression from those unable or unwilling to do radials. That picture I showed you was from Toulouse, where I worked with Professor Jean-Marco. That was from a primary angioplasty we did on a Sunday, and that was way back in 1997. So it needed guts to do radials in those days because it had to be better than a femoral, especially we had no evidence at that time other than just one study by Dr. Kimini. And we pursued radials because we were convinced about the lower bleeding hazard as well as patient comfort. So we started sizing the radials because I trained overseas, and when I came back to India, the arteries were much smaller. So we started sizing the radials using Doppler, color Doppler ultrasound. And this is the mean artery size that we found for the radial arteries in our Indian population was 1.7 in females and 1.8 in males. And based on that, we created the world's first sheath sizing protocol, which was published. And we started selecting our hardware based on this size. And so for a 7 French, one would use at least a 2.2 millimeter radial. For a 6 French, anything around 1.8 would be okay. And for a 5 French, you would need at least a 1.6 millimeter artery. And something smaller than that, we would probably not do radial in those days. Of course, all of these are now shifted down by 0.2 millimeters smaller. And so now we do in even smaller arteries up to 1.1 or 1.2 millimeter radials also. So based on this sheath sizing protocol, we did the country's first transradial rotablation. And this was the case. He was a physician from the same state where I'm working now. And this was the lesion here. You see a very tight LAD lesion. He came in with acute coronary syndrome and received some pre-treatment. And so this was a 7 French XB 3.5 guide. And we used the 7 French because the radial artery was 2.2 millimeters. And so we used a 1.5 millimeter burr. And following that, the balloon still had a waist and, the lesion was not dilatable. So we used a 1.75 burr. You can see the cone of calcium here, it's still visible here. And so subsequently, after a lot of effort, we were able to dilate the lesion and stent it. This was a 4 millimeter stent, and then we post-dilated with a 4.5 millimeter non-compliant balloon. And so that was the final result. So subsequently, we did the country's first 4 French transradial angioplasty in a workshop in 2013 in Gurgaon. And so that was the beginning of the Slender Technique and Radial Club in India. And this is the first series of Slender 5F CTO series that was done by us and published in Indian Heart Journal. And so this is an example from that. And you can see here, we used actually a Judkins guide to do a CTO. This was an oversized 5 French JL 3.5, a little bigger than the aortic root would support, and that gave us good support here. And you can see this was the successfully done. And so we did a series of cases. So important thing is to size it right, which means you need to size the radial and then use your hardware according to that. Even if it's a CTO, you could still use 5 French. It is feasible. Of course, it's an operator choice what he wants to do. This is a very favorite quotation of mine from Charles Darwin. It's not the strongest of the species that survive, not the most intelligent, but the ones most responsive to change. And I've used that in recent times with COVID-19. Ever since the pandemic was declared, we haven't stopped working, we have only adapted to it. And so that has actually helped us understand how to live with it because it's going to stay with us for the next 3 to 4 years. And so recently we changed to distal transradial access. It's been about 2 years now. And we all know about distal transradial access done through the anatomical snub box, and you can see the landmarks here. And we've completed over 3,800 cases now. And this is how a puncture is done. That's the hand position. And this is what it looks like in another view, using the same hardware that we have for transradial access. I've just taken multiple view pictures to show you. Sometimes it's difficult to negotiate a wire, you know, the wire that comes with the turbo sheet or any of the other wires that come, because sometimes it can be tortuous. And so often we use an angioplasty wire to actually get in and then push the cannula in, and then you can subsequently take the angioplasty wire out and you can put the sheath wire in. But again, sometimes you can even track a sheath on that angioplasty wire, as we've shown here, and even a catheter, diagnostic catheter, will track on the angioplasty wire. Even a guide will track on an angioplasty wire if you have a balloon in front of it, not necessarily inflated. It could be just leading, a deflated balloon could be leading the guide catheter end. And this is how we take the sheath out from distal radial access, and this is simply bandaged. A bandage for hemostasis works as well. I haven't used a TR band for almost last 15 to 20 years. And this is for the left radial, for the distal radial access. This is the hand position, usually abducted at 90 degrees. And the same hardware is used for the puncture. And this is the hand position after the puncture is done. This was an obese lady. And so, it makes it easy with probably lesser strain on the back compared to if you were doing a standard radial from on the left side. Now, this is an example of a lady with rheumatoid deformities of the hand. There was difficulty in supination. That's a very important area where distal radial access comes in handy. This was a primary angioplasty. Lady had an inferior MI, short-statured lady, tortuous right subclavian, and a tortuous right coronary. And so it was easy to actually puncture. She could not supinate her hand, so this was a very good thing to do. And you see, this was a very tortuous subclavian, catheter leading there. Sometimes you can use a turbo or an angioplasty wire to cross the tortuosities. And the coronary again was very tortuous, crossed with a run-through wire and subsequently pre-dilated and then stented, 2 stents in, and that was the final result. Another tip is to use a 6-7 GSS. I showed you that if the radial artery size is 2.2 millimeters, we could use 7F, but sometimes the radial artery can be actually much smaller. So there a 6-7 GSS glide sheet slender comes in very useful, which actually gives you inner diameter of 7 with outer diameter of 6. So this is an example of a SKS we did for a patient with post-MI angina following an anterior MI, and he had a LAD D1 lesion. Now this guy also had very tortuous brachial and subclavians. Most of them are plus 60, and so you can have more tortuosities. And so we crossed that using a turbo wire. And this is the diagnostic shot. You can see disease in both LAD and diagonal. It's a big diagonal bifurcation disease. So we decided to do a SKS. And then we used an XB 3 years. That was a 7 French via a 6-7 GSS. And an SKS done between LAD and D1. And you can see both of them dilated here together. And then we post-dilated. And subsequent to that, this was the final result. Coming to difficulty that we find quite commonly is the retroesophageal right subclavian. Sometimes you can have a distal entry of the right subclavian, may not necessarily be a ROSA. We use a PTCA wire, an angioplasty wire, to negotiate these ROSAs. And usually a small guide is useful, like a JL3 or an XB3. Whether it's a circumflex or LAD, small XB or JL is useful. As you can see here, the catheter keeps going into the descending aorta because it's pretty distal, it's a ROSA. So we used a angioplasty wire to deflect into the ascending aorta, and this is a diagnostic in there. And subsequently, we used the JL3 guide to do the angioplasty. And you can see this was a primary angioplasty, and this is the post-dilatation and final result. Another example of a very tortuous right subclavian with a 360-degree loop in the right subclavian and horizontal aorta. In this, we had to use a 4 French diagnostic catheter and then exchange that. We tracked with an angioplasty wire using a 4F diagnostic and then change that angioplasty wire to a 038 wire, and subsequently, that was a 260 centimeter guide wire, and subsequently we were able to take the guide catheter in. So this is the distal radial axis. You see that tortuosity. See that third one is a 360-degree loop. You have 3 tortuosities there. And after a 4 French went in on an angioplasty wire, we changed that for a usual guide, and then we were able to get a XB forum, which actually sat nicely, and the lesion was stented. This is from data study from the invited lecture at TCT 2018. We showed that it takes more time, fails more often, but the benefits of distal radial access are convenience of hemostasis. As I showed you, it's simply a bandage on the distal part of the hand, on the snub box. There's less chance of forearm hematoma, and you still have the availability of the radial artery at the wrist as an alternative access following the distal radial access immediately, because you can sometimes have somebody undergoing an angiogram through a distal radial, and then you want to do an angioplasty 2 hours later or an hour later, and you still have the bandage over the distal radial access, but the standard radial access site at the wrist is still available. And similarly, you can still have the radial artery wrist access site available, supposing in case the patient has a subacute thrombosis immediately following a procedure. So you might be able to use radial still on the same side and do the procedure. Finally, coming to sheathless guide, sometimes the artery is small and you want to use the 7 French or a 6 French sheathlessly because you want to save on the 2 French sizes that the sheath actually uses up. The sheath is actually 2 French bigger than your guide. So sometimes it's useful to go sheathless. Now there are various ways of doing it. You can directly go use a balloon tracking, but now we have the railway system from Cardinal, and this is an example of that. And we did the world's first distal radial access using the railway system. And this was a patient with an Austrian LAD. And as you see here, there's a dilator which goes through the guiding catheter. You can use any guiding catheter, and you can put the dilator from this railway system inside that guiding catheter. They have different sizes, 5 French, 6 French, 7 French compatible. And so the puncture is done as usual, and you have their wire, you put a nick on that, and this is the assembly that tracks in, as I show you here. This is the assembly going on the railway system. So that this is the usual guide, an XB going over the dilator, which comes with the railway system. And so now you can see here the guide catheter, the XB3 is actually sitting into the left main, and we are wiring the ostial LAD stenosis, and the wire goes down into the LAD, and the right, this one here shows the stent being positioned. There's a wire also in the side branch. This is the stent being positioned here, and after positioning, this is the final result. This is the final result in another view. So, and then coming to the last step is to actually downsize the catheter. Now, this is an example of a LAD stenosis in the osteoproximal area, and the right had severe tortuosity in subclavian and a horizontal aorta. We had seen that on the diagnostic, so we didn't want to take the trouble of going through that. We decided to go from the left. And on the left, what we found was a cubital loop, as you see here. So now we didn't go from the right because it was a complex tortuosity in the subclavian 360-degree loop with a horizontal aorta, which takes a lot of effort to get the guide catheter in, do the angioplasty. So we decided to, play it easy and go from the left. And on the left now we had a loop there. And so we were able to bring the 6 French guide with a balloon here, deflated balloon, which was leading on an angioplasty wire. But we got stuck here because this was a high origin of the radial coming from the brachial high up. This is almost the axillary artery. So this is where the radial is originating. And so that had a stenosis. This is a type 3 bifurcation. And so we couldn't advance it any further. So then we decided to back off. And when we backed off, we found an extravasation here. So nevertheless, the rule is don't worry about these. So what we did was we exchanged that, and we took in a 5 French XP3 guide catheter. Fortunately, we had that, and finished the case using an XP3. The lesion was stented, the osteoproximal was stented, and that was the final result you see here. And then on the way back, we took a shot, and the extravasation actually sealed off. So we don't need to worry about those. To conclude, all kinds of complex PCI, primary angioplasty, and challenging anatomies of the radial can be done transradially and distal transradially. And distal radial has the advantage of less forearm hematoma and use of an angioplasty wire to access the distal radial and to negotiate all kinds of bends, whether they are in the radial, brachial, subclavian, makes your life easy. Although you can use a diagnostic on it and then exchange that for a 035 guide wire and take a guide on it. So you can actually exchange and then use the guide, bring the guide catheter up. Downsizing catheter helps, and a GSS and a sheetless railway system can be one of the ways in tackling the smaller radials. And a simple elastic bandage with gauze ball is good enough for hemostasis. Our radial artery occlusion, both with the bandage in distal and for radial, is just 3%, which is the same as what is achieved by using a TR band and patent hemostasis. We don't do patent hemostasis, we just loosen our bandage between 30 minutes to 1 hour, and we don't have to worry about hematomas. And the radial artery occlusion is actually same as what you would find with patent hemostasis, although this is not randomized data, but this is based on more than 1,500 cases of radial access and also 3,800 distal radial access. So this is still in process and might be published soon. So radial and distal radial, we know, are superior to femoral access in terms of bleeding and vascular complications. Survival benefit is superior with radial in PCI for ACS and non-STEMI and STEMI. Many claim that they do 100% radial, but we did some data collection countrywide which revealed that diagnostic angiogram is 70 to 80%, type A and selected PCI is 30 to 40%, but primary angioplasty is still a dismal 2% if you look at the whole country. And that needs to get better. Let's accept the need for training and experience for the sake of our patients. And the Wellness and Radial Intervention Society is committed to providing training and for qualitative assessments on request. Thank you for your time.
Thank you, Sanjay, for beautifully illustrating the tips and tricks for both beginners as well as advanced learners. You have been a pioneer for radials in India. So, Dr. Hiremat, do you have to add something? Do you please unmute? What percentage of cases you do radially and what are the barriers?
No, we do almost 80-90% diagnostics radials, but our percentage penetration for PCI is just around 30%. We have done occasional railway where we needed a 7-French guide, but vastly we are femoralist.
Sanjay, what percentage of patients you do distal radial?
It's our default right now.
It's a default.
It's a default. We have a failure rate of 10% because the arteries can be small. If they are poorly palpable, we don't attempt them. But if we leave those out, we still have a 10% failure because you need a stable hand position, and sometimes the patients don't allow a stable hand position if they're moving. And sometimes the tortuosities, you get into the palmar arch. So it's failure. Our failure is about 10% because we're talking about all comers and the radial arteries are really small. They're probably from 1.1 to 2 millimeters. So the smaller ones, we have more failures. So including that, that's why we have high failures because we don't select out and it's the default.
So
that's the data we have.
Which side do you prefer, left transradial or right distal transradial?
No, we always go right. We always go right unless the right is occluded or if there is a challenge which makes us go left, meaning if the left is bigger and we've gone through the right and seen that there was too much challenge, so we want to avoid, we would go left. But by and large, we don't have any reason to go left unless the right is not available or we find that the right was too challenging and it's probably not worth the trouble.
You also showed that the right is a bigger artery than left in your...
No, sir, in our data, it's right and left are same. The average is still the same, 1.7 in females, 1.8 in males. There's no difference between right and left. We published that in CCI 2013. So we looked at all of that. All of the data is there in that.
So what is, Sanjay, what is your message to the young interventionists who are embarking on their journey, starting their career?
Well, clearly radial has to be the default. I mean, in today's time, you should also have femoral skills. You shouldn't say that you shouldn't have femoral skills, because when you look at structural, you need to go femoral most of the times. I mean, if somebody is trying to develop brachial as an alternative, it will still lose its advantage of what's given by radial, because as we know, when you compare brachial with radial, brachial is actually the whole hand. So obviously for structural preference would be femoral. So people must have those skills for femoral. We should know how to be able to do a good femoral puncture, whether it needs ultrasound guidance or whatever. And secondly, the team should be trained with achieving good hemostasis femorally as well, because that's where the killer is. But there, most of the default work should be transradial. And my suggestion is that they should develop the skills of distal radial access, simply because it gives you the additional advantage of having another access available, which may not be blocked, even when the distal radial is blocked. So, and the complications, the risk of dying is significantly lower with radial. So once they are using that as a default rule, they will be able to deal with the difficult situations, particularly where the benefit is more, as in the obese or in the short stature, where the risk of retrieval bleed is higher. So those are the patients which are more difficult to do. But if somebody is using default access, radial as the default access, for them, overcoming these challenges becomes much easier.
So thank you, Sanjay. I think now we are coming to the end. We have all the talks, and I must thank all the panelists, all the speakers. They have done a tremendous job in this new format. This should be the way forward for the near future in this pandemic. And in the end, I would like to thank Translumina for bringing breakthrough technologies like shock, NC, Pelkala, and Vivo ISAR to India. Translumina is already an established nationally in cardiology, and they have made India proud by making the highest quality drug-eluting stents with longest clinical evidence in the world. Yukon PC is the well-recognized for its safety. So they are basically spearheading the Make in India and Atmanirbhar concept of our Prime Minister of India. This conference, BIC 2020, Best Interventional Cases, is a phenomenal initiative where more than 4,000 cardiologists around the world participated in this virtual format. This current session has been watched by more than 2,700 cardiologists. I must thank Gurmeet, Punita, Dr. Nancy, Nikita, Shantanu, Dr. Ishwar, and the entire clinical and marketing team of Translumina for making this possible. And a small message that all those people who want to review all these sessions or who have missed this session, all these sessions will be available for viewing later. The link will be shared to you very soon. And tomorrow again, there is a session on CTO and cath lab complications from 10 a.m. to 2 p.m. on Sunday. The link will be shared by the Translumina team. So thank you, Translumina, and thank you, everybody.
Thank you.
Thank you for all the kind words you said, sir. Thank you all the panelists, and thank you, Dr. Chandra. With this, we come to the day's end for the second day's end for BIC 2020. I would like to invite all of you to join us tomorrow for the final day. We have a lot of interesting sessions in both Hall A and B. We have CTO, the right tips and tricks, followed by a very interesting session on patient management during COVID-19 real-time experiences. We also have sessions in Hall B, which are unexpected complications in simple cases, missing the invisible dragon, followed by management of peripheral diseases with shockwave IVL. I look forward to seeing all of you there. Good night.